Sir, sir, Wi-Fi password A caps CK. No, sir. At 2016 dollar. 2016 dollar, sir. అవును సార్ ఏసీకే ఏకేసి ఏకేసి సార్ అపోలో నాలెడ్జ్ సిటీ ఏకేసి డాలర్ అంతే సార్. సరే సార్ అది పెట్టేసాం సరే సార్. సార్ ఏకేసి 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 ఏ క్యాప్స్ సి అట్ 2016 డాలర్ సార్. డాలర్ అది కూడా కాదు సార్. అది
Next group, please. Yes.
Myself, I'm Dr. Mauna from Department of Community Medicine. So my question is, what is the most creative excuse you have ever come up with for being late? Honestly speaking, I have never given an excuse. Maybe I would say I have left my things at home, so I went back and came.
Hello all, I'm Dr. Srikanth, Assistant Professor from the Department of General Medicine. So my question is, you are stranded on a deserted island with only 3 items. What are they and how do you survive? So if at all I am stranded on a deserted island, I would like to have my mobile phone, so Harrison's Principles of Internal Medicine, and a Starlink.
Good morning all, I am Dr. Anil Babu, Assistant Professor from the Department of Anesthesiology. So my question is, if you were a ghost, who would you haunt first and why? If I were to become a ghost, I would haunt the person who is responsible for making me a ghost. First, that's my answer.
So it was a team effort.
Good morning to all. I am Dr. Nandishwar, Associate Professor in Respiratory Medicine. So my question is, what's the craziest thing happened to you during your clinical rotation? So bunking a class, going to movie and getting caught there by my professor. Yes.
Good morning. I am Dr. Joshna, Assistant Professor of General Surgery. My question is, what is the best book you have read recently and why did you enjoy? Amit Tripaঠি's Shiva Trilogy. I have been reading because it's mythology, so I enjoy.
Good morning, everyone. I'm Dr. Kavya, Assistant Professor, Department of Pathology, and the question I got was, what's your favorite childhood memory? It's traveling along with my grandma to her house in Babatla and spending time with my family.
Good morning, I am Dr. Sairam from Department of Radio Diagnosis, and my question is, what are the qualities of your favorite teacher? And as I remember, my favorite teachers are always approachable and they always encourage you, and each department we had one, then they used to bring just only 2-3 slides, especially in the pathology department. They used to get some 2-3 slides from Robbins, and they used to tell the whole class, they used to finish the whole class with just 2-3 slides, and they are very they make us very attentive to the class.
Good morning, I'm Dr. Ashish from the Department of Orthopedics. I'm an assistant professor. My question is, if you could have any superpower, what would it be and why? My superpower would be teleportation, so that I could be at many places and you can save the travel time and the expenses.
So good morning one and all. This is myself Dr. Srinivas, Assistant Professor, Pharmacology Department. And my question I got is, what are your thoughts on integrating engineering with medicine? So I will try to find one good functional biomaterials with the help of engineers. And it should be in such a way that it should help the accuracy of the instrument or in detection, assessment and diagnosis and delivering the medicines with respect to global health challenges.
Good morning everyone, myself Dr. Priyanka, Assistant Professor of Pediatrics. The question that I got is, what is the biggest misconception people have about you and how do you wish they could understand you better? Most of them think I am very silent, which I yes. They can know me by spending time with me. They can know me well if they spend time with me.
Good morning all, I'm Dr. Shweta, Assistant Professor in the Department of Anesthesiology. My question is, if you could switch lives with someone for a day, who would it be and why? Rishabh Sharma, a sitarist, because music has the divine power of healing. I want to be him. Thank you.
Good morning everyone. I'm Dr. Sindhuja, Assistant Professor from the Department of ENT. So my question is, if you could create a new medical specialty, what would it be and why? So actually, I thought genetic medicine, so that so we can study or research about the genes and different diseases, so that it will be easy to give treatment, and even artificial intelligence.
Good morning to one and all. My name is Dr. Hemant, Assistant Professor from Pathology. My question is a little interesting. Imagine you're an alien visiting Earth for the first time. What's your first impression and what do you want to explore? I think first impression would be a shock about how they damage Earth, and I'd probably teach them the concept of time travel so they can repair from a different galaxy.
I'm Dr. Jayapriya, Associate Professor, Department of Psychiatry, and I got the question, what's the most important quality or skill you think is necessary for success? Communication skills.
Good morning everyone, myself I'm Dr. Navin. Good morning everyone, myself I'm Dr. Navin from Assistant Professor from Department of Pediatrics. And my question is, what's the most important lesson you have learned from your failure? Failure itself is a lesson. So don't commit the mistakes what you have done in the past. Don't repeat the mistakes. Yes. Thank you.
My name is Dr. Uday Kumar, Assistant Professor General Surgery. My question is, what was your favorite subject and who was your favorite teacher in the medical college and why? My favorite subject is community medicine. My favorite teacher is Dr. P. Harihara Sastry sir, retired Professor General Surgery. The reason I like him is he always says documentation is very important and patients should die peacefully on paper.
Good morning everyone. I am Dr. Geeta I am Assistant Professor in Department of Ophthalmology. My question is, if you could collaborate with any medical professional or researcher, who would it be and why? So I would like to collaborate with Tusha Adiga ma'am because we all know that she has immense interest in research and all, so it would be helpful.
So,
I'll give you the
Good morning all. My name is Dr. Dhananjelu. I am from the Department of Anesthesiology. My question is, what is one piece of advice you give to someone who is just starting the medical journey? Advice I give is enjoy your journey.
So good morning everyone. I am Dr. Govardhan from the Department of Pathology, Assistant Professor. So my question is, what is the most spontaneous thing that you have ever done? It's like the most enjoyed is what I have done in MBBS, ma'am. Just bunking classes and going for movies and games and everything. Thank you.
Good morning, everyone. My name is Dr. Ravikant, Assistant Professor in the Department of Dermatology. My question was, if you could have a third arm, what would you use it for? I will use it for scratching my back.
Good morning all. I am Karthik, Assistant Professor in Forensic Medicine. My question is, what is the most ridiculous thing you used to believe as a child? I believe if you swallow watermelon seeds, plant would grow in stomach.
I am Sai Teja, Associate Professor from the Department of General Surgery. My question is, what's your go-to spontaneous dance move? Can you show us?
Good morning everyone. My name is Dr. Maunika Dyoti. I am from the Department of General Medicine. If you could wear only one color for the rest of your life, which color would you choose? I would choose blue because it represents vastness, sky, ocean. So I would like blue. Yes ma'am, so I like blue a lot.
So my name is Dr. Kadirullah. I am from Department of Orthopedics. I am working as Assistant Professor. So what is the best advice you have ever received and from whom? So the advice what I have received is discipline, dedication and determination is the one which I received from my anatomy professor, Dr. Mudurangappa. Anatomy professor Dr. Mudurangappa in Karnataka, where I am studying MBBS. This is the Siddhartha Medical College. Okay, thank you.
Any more?
Yeah, I think, did we finish everyone? Is there anyone left to introduce themselves? Okay. Yes, thank you everyone. Thank you everyone for being such a sport. And moving forward, now we will start with the inauguration. May I request Dr. Kailash Nath Reddy sir, Professor, Head Microbiology Department, to please come onto the dais. May I request Dr. Alfred Augustine sir, our Dean AIMSR, to kindly occupy the seat on the dais. May I request our observer NMC coordinator, Madam Sarah ma'am, to please come to the dais, please. And I request our Associate Dean ma'am, Ramya Ramakrishna madam, to please occupy her seat on the dais. May I request Kailash sir to please give the welcome address. Thank you.
Respected Dean Sir, Associate Dean Dr. Ramya Ramakrishna Madam, our medical NMC observer, and MU members and curriculum committee members, and all the participants, a warm welcome to all of you for this CISP 3 program, that is a Curriculum Implementation Support Program 3. I welcome our NMC observer. She is Dr. Sarah. She is Associate Professor of ENT from CMC Vellore, and she will be the observer for our CISP 3 program. And I request all the participants to actively participate in this CISP 3 and make it more successful. Thank you.
May I request our beloved Dean sir to kindly speak a few words. Thank you.
Thank you, Dr. Padma. Good morning to you all. Dignitaries on the dais, all the faculty who are here for the CISP, and the faculty, the resource persons. Good morning to you all. As usual, I start off by saying that our medical education unit and curriculum committee, they are doing a great job. All of you know they're doing an FDP every month. They're doing programs like the BCME and now the CISP. These are all essential programs for us to implement CBME. And I'm glad the whole set of clinical faculty are here, because from what we have observed, our implementation of CBME is very good in phase 1 and phase 2. It's very high. But we need some catching up to do in the phase 3 subjects, and this is the first step to make that happen. I should appreciate our Nodal Center Observer on behalf of NMC, Dr. Sarah, for coming. Thank you very much, madam. For the participants, this is a unique opportunity for you to understand how to implement CBME. See, the word CBME has become so commonplace now, we don't think twice about it. But for those of you who have spent some time and looked at it, it's actually a very good curriculum if we implement it fully. It will make significant changes to the way our students will learn. Unfortunately, many of us with our clinical work pressures and other pressures, we don't focus on it, especially in the phase 3, and therefore this program has been held. So this CISP 3 will really help you to implement the CBME, and that can only have a positive effect on our students. If you look at how first MBBS phase 1 and phase 2 students have benefited from it, you will realize that we must implement this in phase 3 as well. The temptation is strong to stick to our old ways of teaching and not move from there. We must overcome this. We must be open to this change. Take as much as you can from this program, small incremental changes, and I'm sure in 1 or 2 years you'll realize that this program was useful for you. Without, you may not realize it right now, but 1 or 2 years from now you'll realize how much it has helped you. You'll realize that when your students come and tell you how different they have learnt medicine suddenly. So good luck to all the participants. Please participate wholeheartedly. Actively engage with the exercises which you are supposed to do, and then it will be beneficial to you all. Please join me in a round of applause for the curriculum committee and the medical education unit for organizing this. Thank you very much.
Thank you for the words of advice, sir. Thank you. May I request our NMC coordinator, Madam Dr. Sara, to please speak a few words.
Good morning, everyone. I'm so glad to be here in the midst of us, all of you, to see how it's going in Apollo Chittoor. This is my first time coming here. Very encouraged to see the Department of Medical Education and the work they are doing here. A few things which I've learned being a part of the Medical Education Department from CMC and the Nodal Center is that earlier I used to think there's no science behind education and learning. My teachers taught me, some other teachers taught them, and they are teaching me, and that's the same thing I'm going to do. But being part of the education department, I've realized that there's so much science, so much organizing and so much planning to go, how we teach and what the students are supposed to learn and how they're going to implement the same. And today, our whole program is focused on the different methods of teaching and learning and making our education a better system where there is meaning and understanding behind everything we teach and they learn. Thank you. All the best for the program today.
Thank you, Dr. Sara. Now I request our beloved Ramya Ramakrishnan Madam to propose the vote of thanks.
Good morning to all, and I think right at the beginning of program itself I'm going to thank you all. I think I should thank all of us, all the members of MEU and CC for having effectively and very actively worked towards planning this program with the help of our Nodal Center, of course, and a great thanks to Dr. Sarah, Dr. Margaret Shanti, and of course ever busy Mr. Manikandan, who helps us and gives us all the tips and tricks how to go about arranging the program. So first of all, let me thank them, and of course I want to thank all the participants. Everybody is busy in their own clinical schedule and hospital work and lab work, etc. But I'm happy that all of them shared the breakfast with us and was on time here to start the program and do the ice breaking. And we had wonderful answers for the various difficult questions Padma had posted. And that's a nice way to start the day. Thank you very much for that. I want to thank our Dean, Dr. Alfred J. Augustin, for always encouraging us to get one more FDP, get some more resource persons, and keep the faculty equipped to deal with the CBME. Thank you very much. Of course, Dr. Kailasnath Reddy sir has been a pillar of strength with his wisdom, advice, his experience in various medical colleges and in teaching, and he always has a quiet word to add to our planning, and thank you very much, sir, for that. And of course, I have to thank the support staff, the audio, video, my secretary, Ms. Rekha, who's been in touch with most of you trying to get your details, and the facility manager, and of course the Chief Operation Officer, Naresh Kumar sir, too, for helping us organize this program. And a big thanks to our Vice Chancellor of the Apollo University, Dr. Vinod Bhatt sir, who encouraged us to start using this seminar hall in the academic block for all our FDPs. And so this is our first FDP we are conducting here. And I'm sure all of you are impressed with the ambience and the no noise pollution here. And so hopefully we'll have a happy learning and not much sleeping. So thank you very much once again. And hopefully we'll have a good learning at the end of 2 days. Thank you.
Thank you, ma'am. Thank you for all your efforts for providing us an AC room, which is very much required. Thank you so much. Yeah, you are not done yet with me. So, next thing is about introduction. What do you understand by CISP? What is CISP? As the name suggests, it is curriculum. Is it working? It's a curriculum implementation support program. So, what we are learning is a program which supports the implementation of the CBME. Okay. So, introduction, main objectives. I'm going to talk about the key components and benefits of CISP. Main objective is curriculum implementation. So, what curriculum are we talking about? CBME, which is an outcome-based curriculum, isn't it? I think you're all familiar with. You're all finished your BCME. Then, second thing is faculty development. Conduct many FDPs, faculty development. It fosters collaboration and sharing among different medical colleges. Development and implementation of valid, reliable assessment methods. So these are the main objectives of the CISP. And how is this curriculum implementation done? There's curriculum review and mapping. Already the curriculum has been given in the form of objective. We have been given volume 1, volume 2, volume 3. You have all, so CBME framework has already been given with the hard work of many NMC members. So we have faculty development programs, faculty training and workshops being conducted. It's teaching about CBME, teaching about learning methods, assessment methods. Then we have mentorship and coaching for the implementation of CBME. That's the main key components I'm talking about. And it supports assessment and evaluation. Okay. So is it beneficial? Sorry for the interruption. So is the CISP beneficial? Yes. We learn to have a better implementation of the CBME curriculum, enhance the faculty capacity because we have plenty of SDPs being done. And we learn how to better assess the students. It should be valid and reliable assessment. And of course, increased collaboration, you know the benefits of integrating with, collaborating with other departments. So it's a 2 days workshop where a program wherein we talk about the principles of CBME, which you have already learned. We'll just revise a few. We'll talk about alignment and integration, assessment of CBME, skill training and assessment, electives, early clinical exposure, ADCOM, curriculum governance, student-doctor methods of clinical training, and record maintenance. This is how we are going to go about the various plan what we have for the CISP for 2 days. Okay, so this is just an introduction. Now I would acknowledge the help rendered by our NMC Executive Committee who has formulated these slides. So curriculum, the component, so once you learn about CISP, we are, first is the principles of CBME. CBME is what? Competency-based medical education, okay? So we are going to learn about this in these following objectives. We are going to first define what is competency, differentiate between competency, objectives, and outcome. We'll talk about the salient features, differentiating the CBME from the traditional method. Specify again goal, roles, and competencies of Indian medical graduate. IMG stands for Indian medical graduate. So, what is competency? Can anyone tell me what is competency? You have the books right in front of you. Can one of you tell me what is competency? Can one of you read it? What is competency?
Competency is the observable ability of the habitual and judicious use of communication, knowledge, technical skills, clinical reasoning, emotions, values, and reflection in daily practice for the benefit of individual and community being served.
So, in other words, to say what should you have,
or what should have changed.
What should have changed. Well, each and every word here is very important, okay? A habitual. What does habitual means? It should have become a habit. Daily you have to practice that, okay? Sorry? Regular. Okay, that's the right word. So, habitual, judicious use of what? Of communication, knowledge, technical skill. So, you remember all your domains? Bloom's taxonomy, isn't it? You remember all that. So, communication, knowledge, technical skills, clinical reasoning, emotion, values, as well as reflection. Emphasis is on reflection in daily practice. It should become a routine for you all as a day-to-day practice. For what? For the benefit of the individual as well as the community being served. So what is the main objective here is IMG being the physician of first contact should have competencies which are globally relevant. Okay, are you guys following what I'm trying to tell? Okay, so what should you have and what should have changed? So example, they have provided the Indian medical graduate should provide first aid to the trauma victim. Is it important? Is it relevant? So this is a part of competencies. I think you can read out your own competencies in your respective subjects which has been given. So having known about competency, what is objective? So what are objectives? Yes, you learned about smart objectives. Ma'am, can you please read out what has been there? What are objectives?
They are clear statements regarding what a learner will be able to do at the end of a learning period they could not do before.
Isn't it? Which he wouldn't have been able to do it before, but he is now able to do at the end of the learning session. So at the end of my session, you should be in a position to tell all the principles of CBME. Okay, that is the objective. So we are mainly concentrating on Indian medical graduates. So what the Indian medical graduate should know, do, or behave. For example, Indian medical graduate should be able to apply occlusion bandage to a bleeding wound. Okay, a clear statement. Okay, very specific. As Madam was telling about the SMART criteria, isn't it? You remember that. So that is the objective. So we finished with what is competency. We finished with what is objective. We'll look at what is CBME. What is CBME, sir?
an outcomes-based approach to the design, implementation, assessment, and evaluation of a medical education program using an organized framework of competencies.
You have been given an organized set of competencies in your own subject. So using that competency, which forms the core of the curriculum, so what are we trying to do is we are going to design, implement, assess, and evaluate the medical student or medical education program. Okay, so that's the reason CBME is an outcome-based approach. What the student should know, what the student should be able to do, okay, at the end. So this is CBME. So for example, NMC says the Indian medical graduate should become a clinician. Clinician who understands, provides preventive, promotive, curative, palliative, holistic care with passion. Okay, for that to be a clinician, what he should have? He should demonstrate knowledge. Yes, knowledge of all this normal human structure, function, development from a molecular, cellular, biological, clinical, behavioral, and social perspective. One thing. Second, he should demonstrate an ability to elicit and record a history that is complete, relevant to a disease identification, disease prevention, and health promotion. Isn't it necessary for a clinician? Yes. Not only that, it doesn't stop there. He should demonstrate the ability to perform a physical examination. He should be in a position to choose appropriate diagnostic tests and interpret these tests also. Then he has to demonstrate an ability to prescribe and safely administer the appropriate therapies. This is just for a clinician, and that has been broken down into various, various statements as of now. Okay. So, what is the paradigm of CBME? What does a CBME model exactly consist of? Paradigm is a model. So, healthcare delivery has one goal. Okay. Has one goal in the sense has a goal, and to meet that goals, the Indian medical graduates has to perform many roles. To perform these roles, he needs certain competencies, and to attain these competencies, there are certain objectives which are there, and there is a continuous ongoing assessment being there. So this is the paradigm or the model of CBME. Are you guys following? Yes? Yes. So what I just, moving back, so what do you think this is? This is a goal. Okay? To attain these goals, what you need to have? You need to demonstrate the ability to perform a physical examination. Okay? So there are various objectives. So let us come to that. So what is the goal? Goal is a
projected state of affairs that a person or a system plans to achieve. In other words, where do you want to go or what you want to become?
Okay, goal. So as per the goal of NMC undergraduate medical education, the UG medical education program is mainly designed with the goal to create an IMG or Indian medical graduate who is possessing requisite knowledge, skill, attitude, values, responsiveness, so that he or she may function appropriately, effectively as a physician of first contact of the community, at the same time being globally relevant. What does that mean, globally relevant? Yes, sir. Yes, sir.
Should be acceptable universally or internationally? Universally,
yes. That should be a standard, golden standard care. Am I clear about this? So that is the goal of NMC which an Indian medical graduate should attend. So he should be a clinician. We just spoke about various attributes of a clinician. Not only that, there are other goals also, like lifelong learner. He should be a leader. He should be a team member. As Madam said, a good communicator for a success. Okay? And he should be a professional. So what is about this clinician thing? Here's someone from here.
Who understands and provides preventive, promotive, curative, palliative and holistic care with compassion.
So role, it's a role. Okay, first role as a clinician. Okay, second role.
Leader and member of the healthcare system, team and system with capabilities to collect, analyze, synthesize and communicate health data appropriately.
Thank you, Madam. So, third role.
Communicator with patients, families, colleagues and community.
Yes.
Lifelong learner committed to continuous improvement of skills and knowledge. Professional who is committed to excellence, is ethical, responsive and accountable to patients, community and profession.
Okay. So these are the various roles of the Indian medical graduate. So IMG has various roles. If you are sleeping. So these roles are being divided, they are globally relevant, so they have been divided into global competencies, and each global competencies have been further divided into sub-competencies, which can also be called as objectives. Okay? So if you just turn to your volume, you have your laptops, isn't it? Volume, not that book, not the CISP book. Volume 1, Volume 2, Volume 3. I think it just, I know that it is, this slide is not very clear, but understanding the competency table, what it says, first thing is the number. I think you're all familiar with this table. You've seen this, isn't it? In the, so first thing is the number. Then we have the competencies being written. Number can be here, it is PY is physiology. Then they have described the competencies. They have even described the domain. What are all the 3 domains we are talking about? Knowledge, skill, attitude domain. Okay, even C is been also included here. C is also included. That is communication also been included. Okay, so then we have the knows how, shows how, performs. Okay, it's all part of what is called as the Miller's pyramid. You remember all this Miller's pyramid? Okay, then we have whether the core competency, must know, good to know, nice to know. So must know is the core. Okay, whether they are identifies the competency as core or desirable. Suggest teaching learning methods. So it also, they have already given us what teaching learning methods and what assessment methods to be used. Then certifiable competencies also have been mentioned. Then whether this topic has to be integrated vertically or horizontally also has been mentioned. It's already spoon-fed to us. So we need to just implement these things. Coming to specific learning objectives. So what all we learned till now? So what did we learn till now? We learned about competencies, we learned about objectives, roles. Yes, we learned about the roles of the IMG, Indian Medical Graduate, isn't various roles, goals. Then we are talking about specific learning objectives. You remember we framed few, we gave you competencies and you had framed those specific learning objectives using those objectives. So you as clearly stated, it is clear statements of which of what a learner should be able to do at the end of the specific learning experience. So what the Indian medical graduate should know, knowledge, what he should do, should have a clear-cut skill, how should he behave, that is the clear statement. Knowledge, skill, attitude and communication. Don't forget the communication thing. So this is out of the an extra slide, how to frame education, just for revision. Madam was talking about SMART criteria for SLOs, specific, measurable, observable, attainable, relevant, timely. I think we gave you the ABCD method to frame the competencies. You could remember? Yes, it has audience, behavior, condition, degree, ABCD. Okay? So if possible, please revise all that. Take the competency. We think we are already framing those competencies. So if you are not, please do it. Now, it was Benjamin Bloom way back in the 1956 who is called the father of taxonomy of educational objectives. So he is the one who mainly stated that learning is a behavioral change. Behavioral change in what? In the knowledge or thinking, feeling, and motor skill, which are being divided as a cognitive, affective, or attitudinal and psychomotor domains. These are, and each domains has further hierarchical levels. You could recall up to creative levels, if you can just recall what I'm trying to tell you. So this is the behavioral change which Bloom taxonomy talks about. So goals, global competencies, sub-competencies, SLOs, specific learning objective. This is the hierarchical level of the division. I think you're all familiar with these. So now what is the difference between goal? Goal is a projected state of affair a person or a system should achieve, plans to achieve. Competencies are observable ability of a health profession, integrating multiple components like knowledge, skill, values, attitude, communication. Objectives are statements which the learner should be able to do at the end of a specific learning experience. Examples? Goal is to produce skilled basic doctor at the end of internship. For that, the competency should be able to manage common disease seen in OPD correctly, able to perform basic procedures correctly in a trauma care, should be able to demonstrate effective communication skill when interacting with the patient's relatives or team members. Specific statements should be able to describe different types of fractures, should diagnose fracture by physical examination correctly, able to provide first aid, able to plan basic investigations in case of fractures, counsel family members of a patient with head injury, identify the need for referral if required correctly with appropriate thing. Yes, I think you are also familiar with this slide. Now here is an exercise just to wake you all up. So these are the statements. You need to divide them either as goals, roles, or objectives. Okay? So what is the first one? The group blue will take the first one. Develop, negotiate, implement patient management plan. What do you think it is? It's a competency. Develop, negotiate, implement patient management plan. You take 1 minute time. Next group, learn every aspect of national health policies and devote himself or herself to the practical implementation. So, 1 minute. I'll take the fourth one. The third, position the patient and demonstrate the technique to palpate the spleen correctly. You're going to elicit a history of occupational exposure in patients with history of asthma, must demonstrate responsiveness to a patient that supersedes self-interest. Where do you include it? Is it a goal, role, competency? Like practice holistic medicine. Practicing holistic medicine is a very broad term. So what it is? It is a role. I shouldn't have pushed that. Ma'am? Ma'am, this... Okay, ready? Yes, what do you think the first one answer is? You didn't see the answer slide. Yes, 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 yes. It's a competency. Okay, fine. Second one is the goal. Okay, sir. Ma'am, third. Third, position the patient, demonstrate the technique. That's a specific learning objective. Yes, ma'am. Fifth one. Elicit a history of occupational exposure in patient with history of asthma. We had argued about this earlier also. You think it is a goal? Elicit a history. It's objective. Two schools of thoughts. Okay, we'll come to that. Okay, sixth one. Must demonstrate responsiveness to a patient that supersedes self-interest. Competency. Okay, fine. So you all have answered correctly, ma'am? You have all answered correctly, but this, see, sometimes it so happens that a competency looks like a specific learning objective. That's also fine, either way. But a competency will have too many verbs, like too many components of specific learning objectives. Specific learning objective, clear statement, what, one thing, okay? So please remember this. So I think you're all familiar with goal, roles, all that. Now, next activity, think, pair, share. Flip charts have been given to you all. I want you all to take 7 minutes. We are running short of time. Less than 7 is also fine. So differences between traditional as well as competency-based curriculum. So please jot down the differences, and we'll come back to the discussion. Okay, please do it as, I think you're all familiar with the differences. Don't turn pages. Whatever you know, you write. You have experience, whatever is your experience. You have been used to your traditional way of teaching. Now you are doing the CBME way of teaching. So what differences do you? Yeah. So write the differences on a flip chart. Madam, AI konja time. I'm just joking. Yes, 1 more minute. If everyone are done, we can. Okay, we'll start with this group. Why only always group? Yes, yellow group first. No elect. We learn from students also so many things. We'll start with, yes, your attention please. We'll start with group yellow. Yes, one of you can, sir, you can start. The differences between traditional and CBME. So first, you'll talk about traditional and simultaneously talk about CBME. How are you going to talk about? Longitudinal, vertical. Both the same. But longitudinal, horizontal. Listen, please. Can I have your attention? Yes.
CBME is interactive teaching.
Yes, ma'am.
Traditional teaching is teacher-centered, and CBME is more of student-centered.
Yes.
And in traditional teaching, it is less structured, and CBME curriculum is more structured.
Okay.
There is no stakeholder feedback in traditional curriculum. There is a stakeholder feedback in CBME.
Who is the stakeholder here, ma'am?
Students.
Student stakeholder. Okay.
And there is no integration in traditional curriculum. There
Okay.
is horizontal and vertical integration in
Yes, yes.
there is no formative assessment in traditional.
Yes.
There is formative and summative assessment.
It's meant after each side. Yes, ma'am.
And there is no electives in
Correct. We didn't have electives.
CBME, there is electives.
Electives. And also,
Skill-based lab and
skills were not there. Early clinical exposure were not there in the traditional one. Yes, ma'am. Thank you so much. Can we have a big round of applause for them? We'll move on to red. After yellow is red. Okay.
Traditional methods, you have non-specific learning objectives or goals. Means you don't have specific goals.
There are no specific goals in traditional, okay ma'am, traditional teaching?
CBME, you have specific goals.
Okay.
And it's a passive learning method in traditional.
What do you mean by that? Passive learning means what?
Only like theoretical, by the end of, only teaching.
Only teaching, the teacher talking. There is no interactive.
Yeah,
Okay, okay, fine.
But
So
CBME,
what do you think this is? Is it interactive or didactic? Interactive session. Okay, ma'am.
CBME, it's active learning, ma'am, where you have both.
Okay.
In traditional, it's summative assessment.
Summative assessment, yes.
In CBME, you have both summative and
We
formative.
do internal assessment also, no? That is formative.
But this you have monthly
Okay.
assessments. But
Monthly,
that is only
yeah.
for examination.
Summative assessment is given high weightage in case of traditional teaching, whereas here it is the formative assessment. That's what you came. Okay.
And you have early clinical exposure is not seen in
Correct.
traditional. In CBME, you have very early clinical exposure.
Yes.
And no integration.
No integration was there. Yes,
Yeah, you have
ma'am. Whereas integration is there.
Feedback from the students.
Students,
is not
yes, I think you have covered almost this thing. Okay, we'll go to green. Oh, here.
Because so ours is first is content, traditional content based, more focus on content. In traditional medical education, is monotonous, and in competency it is always two separate points. It is.
Oh, it is tradition is content based.
Here it is competency based.
Okay, tradition is monotonous.
Monotonous.
This competency is okay. Two
way.
way.
And then it's teacher centric in traditional.
Okay.
Here it is student centric.
Student centric.
And there will be like no scope for feedback in traditional and scope for feedback, and there will be continuous improvement
Okay.
with respect to feedback.
Aithu.
And then relatively it is not effective. Assessment will be not effective in traditional, if at all if it is done. But here it is more effective with regard to periodic assessments. Assessments will be more.
In tradition, assessment is not effective means what?
Why? Because we will be doing assessments like say after 6 months or 1 year initially.
You mean to say frequency of assessment is not more? Huh?
Yes.
Okay.
With respect to frequency, there will be continuous improvement.
Okay, okay, ma'am.
And then non-structural in traditional, in competency it is structured.
What is that? Non-structured curriculum?
Curriculum.
Curriculum is not structured,
yes.
you're saying.
Alignment will be not there in traditional.
Okay.
Here it is alignment, integration, which helps focus to students. And even teaching learning methods, when it is employed, it is various in number in competency, which can induce interest in students with respect to mannequins. All this.
Okay, thank you so much. Can we have a big round of applause for them? Did we give you an applause? Yes, we'll move on to the next group, sir.
Everything has been covered already.
It doesn't matter.
Okay. So the traditional way of teaching is teacher-centric and CBME is student-centric. Yes. The curriculum is haphazard in traditional way, whereas it is well-planned in CBME. And no emphasis on integration was there in traditional. And the CBME has both vertical and horizontal integration of subjects. And there is less emphasis on feedback in traditional way. We have continuous directly observed feedback in CBME curriculum. And there is less emphasis on interaction as well in traditional way. And in CBME there is more chance for interaction with the students. And there are a few summative assessments in traditional way, and we have multiple formative assessments in CBME.
Thank you. Thank you. We'll have, very good. Give them a round of applause. Did we finish here? Pink.
Ma'am, I think most of it is covered.
What extra is there, you tell me?
I think the timetable designing is a complex thing in the CBME. We have like initially name and faculty name and subtopic. These many hours are allotted is also not specified in the old timetable. But in the new timetable, we have more for small group discussions rather than for lectures, which was previously more. And we have self-directed learning classes. And also, the new schedule also included remedial classes. And it differentiates slow and fast learning. And the AdCom foundation, it was already...
Yes, so your BCME training was more effective. So everyone have come up with correct answers. So competency-based medical education is a model wherein the it's mainly centered on the student. Okay, main focus is on the mastery of competency, and it is based on assessment is mainly based on the learning outcome. So these three things, please keep in mind. An outcome-based approach mainly designed to implement, it's an approach to the design, implement, assess, evaluate medical education program using an organized framework of competency. The second sentence is very important. It de-emphasizes time-based training, promising greater accountability, flexibility, and learner-centeredness. So it is contextual, focuses on outcomes, formulated as specific competencies. It is independent of the length of time in training. It's not about time, but it is about what the student knows or is able to do. It allows for individualized learning, flexible, self-paced clinical workplace, and students are in charge of their education as never before. So the onus lies on mainly the students. They are responsible for their own learning in curriculum in CBME. Hopefully, so the earlier traditional method, there was curriculum which was there, from which we derived the educational objectives, and the assessment also was based on that. But now in competency-based medical education or model, what do we first consider? The health needs of the society. That is taken into account. Based on that, the competencies or the outcomes have been formulated, and that constitute the curriculum. So what is the driving force here? It is the health needs, whereas here is just a curriculum. Okay, so curriculum drives assessment. Here it's mainly the competencies or the health needs from which we have the assessment being framed. Is this fine? Is this model fine? So traditional variable undefined outcomes not aligned with society needs. Emphasis mainly is on the recall or just the knowledge. We don't, say in traditional we don't assess for attitude or communication. Okay, whereas in CBME we do that. No formal training on attitude and communication is done here. So we have a list of table here. I think it's been shared. If you want, I'll share it to you. So the differences between competencies and CBME. Starting from driving force, here is the content, here is the outcome. Here is acquisition of knowledge, here it is mainly application. Applied knowledge is taken into consideration. Driving force for the process, here is the teacher, here is the student. Responsibility for the content, here teacher, both the teacher and the students are responsible in competency-based medical education. Goal of educational encounter, knowledge acquisition, here is application. Assessment tool, it is single and it is subjective. Here multiple. Assessment tool, what we use, 360-degree assessment, isn't it, for the students. Here, assessment, typical assessment tool. Assessment tool here is proxy, we are authentic. Okay, what do you understand by proxy? Indirect. It's indirect. Okay, for example, I'll think the student who has scored 90 in exam is going to be a very good doctor. I don't know whether how he is going to, I'm not here, I'm just based on his knowledge, I'm trying to assess his, skill. Okay? Here it is not, I don't know whether he is able to do a suture, whether he is able to handle the patient correctly, no. So, setting for assessment, here it is direct observation, here it is indirect. So, assessment norm referred, here it is criterion referred. Timing for assessment is mainly emphasis on the summative. Annual exams, here it is formative. So, both formative and also summative is given, but morely the formative assessment is taken to emphasis. Program completion has got a fixed time here, we have variable time. So, depends upon whether the student is able to learn that in that particular, whether that milestone has been acquired or not. So, based on that, he moves forward to that. So, time independent. If this is fine. So, I think the student progression happens in this manner, specific learning objectives, sub-objectives, I think you are familiar with this. To summarize, this is my last slide. Competency-based medical education is an outcome-based approach. Design, implement, assess, evaluate medical education program using an organized framework of competencies. The Indian medical graduate attained these competencies by the learning objectives in every teaching learning session. CBME has certain advantages as compared to the traditional curriculum. Do you all agree with this? Yes? Yeah. So, these are some of the suggested readings from the NMC, and I acknowledge with thanks the NMC committee members for this slides. Thank you. Any questions? I'll ask questions.
request everyone to please come back to your seats.
Good morning to all of you. So this topic is on graduate medical education regulations, GMER, framed by National Medical Commission. And these regulations were first introduced in the year 2019 when competency-based medical education program was started. So this competency medical education program was started in the year 2019. Already the first batch completed their internship and left, and second batch they are doing internship 2020 batch, and the 2021 batch is right now in final is part 2. So this document is prepared by the Medical Council of India. The objectives of this session is the learner will be able to enumerate the major salient features of the regulations on graduate medical education regulations. It is available in the website and you can go through that document. First document was released in the year 2019. Then later it was modified because of COVID pandemic. The academic program was very much disturbed and NMC had modified that document twice. Once in 2021, regulations were changed for 2021 batch. Later again they modified for 2022 batch. Now in 2023 again they introduced a new regulations, competency based medical education curriculum regulations 2023. National Medical Commission, these were the regulations. At present, we follow these regulations for the batches 2021, 22 and 23. And whereas a new set of guidelines have been given again for 2024 batch, that is a competency-based medical education curriculum 2024. This is the latest one and this is for 2024 batch onwards. So the first MBBS students who got admitted in the year 2024, the rules and regulations will be followed based on these competency-based medical education regulations 2024. Whereas 2021, 22, 23 batches, right now they are in with us. We follow the regulations issued in the 2023. Under 2019 document, now it is not a valid document. So this was the 2019 when MCA was totally abolished and NMC was yet to be established. At that time, the government of India appointed Board of Governors in supersession. They formulated these guidelines and they named as a Regulations on Graduate Medical Education Amendment 2019, where the CVME program was launched. So this is the CVME Regulations 2023 that is applicable for 2021, 22, 23 with retrospective effect. Effective from the date of its publication in the Gazette, that is 1st August 2023, but it is applicable for the previous batches also 2021 and 22, whereas the 24 regulations are not applicable for the previous batches. 2024 regulations are applicable only prospectively, that is from 2024 onwards. Already you know what is the roles and of a Indian medical graduate. This was documented in the National Medical Commission. Already these two who participated in that basic course in medical education, they know very well about these, the rules and regulation of the rules of the Indian medical graduate. The undergraduate medical education program is designed with a goal to create an Indian medical graduate. So Indian medical graduate must possess a requisite knowledge, skills, attitudes, values, and responsiveness. This is absolutely necessary for an Indian medical graduate. He is the first person, first contact of the community as a physician. And globally relevant. So as per the NMC document, an Indian medical graduate must possess requisite knowledge, skills, attitudes, values, and responsiveness. And he is the first physician, first contact of the community as a physician, and globally relevant. So these are the 5 roles of an Indian medical graduate defined by National Medical Commission. First is the clinician. Second, he is the leader. Third, he is the communicator. Fourth, he is the lifelong learner. And fifth is the professional. These are the 5 goals of an Indian medical graduate, 5 roles of an Indian medical graduate. As a clinician who understands and provides preventive, promotive, curative, palliative, and holistic care with compassion. That was his responsibility as an Indian medical graduate. And he is the leader, shall be the leader and a member of the healthcare team and system. He must have the ability to collect, analyze, synthesize, and communicate health data appropriately. He must be able to communicate properly with the patients, families, colleagues, and community. And he must be a lifelong learner, committed to continuous improvement of skills and knowledge. And he must be a professional who is committed to excellence, is ethical, responsive, and accountable to patients, community, and profession. So these are the roles of an Indian medical graduate defined by National Medical Commission, and we have to train our students in this format. Same thing, clinician, lifelong learner, leader and a team member, communicator, and professional. So the training format, broad outline, foundation course. So there are various components that were implemented in the curriculum in 2019. So in addition to the regular subjects, they started foundation course. The duration of the foundation course is variable. First it started with 1 year, 1 month, then it was reduced to 1 week and spread over a period of 6 months. And the next, the latest one is a 2 weeks time. And the foundation course will be at the beginning of the first MBBS course. Then integration is one of the top priority in the new curriculum. And the integration is either vertical or horizontal integration. And it must be implemented at all phases. For example, in case of microbiology, recently we conducted an integrated program on tuberculosis where the Department of Pharmacology, Pathology, General Medicine, Pulmonary Medicine, and microbiology departments, they participated in that integrated teaching program. So both vertical as well as horizontal integrated teaching program is one of the components of the curriculum. Teaching learning methods. We will have a class on every topic. And early clinical exposure is another new component that was introduced in the curriculum. And this early clinical exposure is during the first phase of MBBS. And the skill acquisition is a part of the program from first MBBS to the final MBBS part 2, utilizing the skill laboratories, skill lab. And experience in patient care, diagnostic and skills lab, that is regular clinical postings. Community-based approach, a new concept has been developed, that is a family adoption program, that each student is attached to 3 or 5 families, and the Department of Community Medicine will organize this program. And this family adoption program will be there from the first MBBS to the final MBBS part 2. And the student is associated with those 5 families throughout his MBBS career. That is a family adoption program. AdCom is another component that was introduced in the curriculum, that is attitude, ethics, and communication. And this program is throughout all the phases, phase 1, phase 2, phase 3, and phase part 1 and part 2. And AdCom, they also a part of the university examination. There shall be one short answer question on AdCom in each and every paper, from first MBBS to the final MBBS part 2. And AdCom, the NMC had given the guidelines, and AdCom module is there, and allotted to each department. The modules have been allotted to each department by NMC itself. Structural periodic assessment, both formative assessment and summative assessment, or the summative assessment will be done by the university. Formative assessment and class tests, etc., we have to conduct and assess the student periodically. So these are the various components that were introduced in the curriculum, that is of the CBME program. One is the foundation course in the first MBBS, and the integration is the important, and teaching learning methods, where the 1/3 is only didactic lectures, where the 2/3 is the small group teaching, that is the most important, and early clinical exposure during the first MBBS, and a skill lab, then family adoption program, attitude, ethics, and communication. These are all the new components that were introduced in the curriculum, that is the CBME of 2019. Faculty development programs is also part of the program. So alignment and integration is the next topic for you, and Madam will discuss more about this alignment and integration, and various teaching learning methods. The most important as per the NMC is 1/3 didactic lectures, but we got accustomed to 90% for lectures, but now the concept is 1/3 for didactic lectures and 2/3 for interactive sessions, practicals, and clinics. So during total teaching hours, 1/3 is only didactic lectures, and we had to plan our timetable in such a way that 1/3 is there for lectures, whereas 2/3 is a small group discussion. Small group discussion is the top priority in a new document, and a small group meant only 15 to 20 students, and a clinical posting, bedside clinics, doesn't come under the part of a small group teaching. Small clinic postings doesn't come under that small group teaching. Interactive learning methods, case-based learning, guided self-directed learning. Self-directed learning is another new concept that was introduced in the curriculum. So these are the components, different components come under the teaching and learning methods. Now 1 hour will be there on to discuss about these teaching learning methods by one of our faculty members. So lecture already I told you 1/3 of the classes, small group discussion 2/3, whereas in practicals this is a DOAP, that is a demonstrate and observe and assistance and perform. That is the concept of the NMC, that is the student must be, first we have to demonstrate, then student will observe and he will assist and then he will perform. So that is the composite, that is the competency required for the student to improve his skills. Skill lab is available, and there are various procedures that have been listed out by NMC under a skill lab, and this skill lab will be utilized by the students from phase 1 to phase 3 part 2. So every year students will acquire certain skills using skill lab. So these are some of the procedures listed out in the document: venipuncture, intramuscular injection, intradermal injection, subcutaneous injection, intravenous injection, like that, and a basic life support, oxygen therapy, aerosol therapy. All these are some of the examples that have been given in the NMC document under the skills program. So AdCom is another component that was introduced in the curriculum, and this is the module available in the NMC website. And NMC itself has divided the modules to various departments. All internal and university exams must have one question application based question on AdCom in each theory paper. So each and every theory paper will have one short answer question on AdCom. It should be assessed in various components of practical clinical exam also. Even in microbiology, we have an AdCom exercise as one of the practical exercises. In the same way, Each theory paper will have one question related to the AdCom. Whereas anatomy department, they will deal with the 1.4, 1.5 module. In the paper 1, the question comes from 1.5 module. In paper 2, the question comes from 1.4 module. So this is also already decided by the NMC, and our job is to implement this. For physiology, it is a 1.2, 1.3, biochemistry 1.1, like that, microbiology 2.1, 2.8, pharmacology 2.2, 2.3, 2.5, pathology 2.4, 2.7. These are the module numbers given in the AdCom module book, and NMC had allotted this to various departments. Part 1, ophthalmology ENT 3.1, 3.3, forensic medicine 3.4, community medicine 3.2, 3.5, and general medicine 4.1, 4.3, surgery 4.4, 4.5, 4.6, OBG 4.2, 4.7, 4.8, pediatrics 4.9. So each question will come from that particular module in that particular paper. So electives is another new component that was introduced in the curriculum under CBME program, and these electives to provide opportunities for diverse learning experiences and research community projects during study period. And these electives will be after completion of final MBBS part 1, that is a phase 3 MBBS part 1, and before he starts phase 3 part 2, that is in between phase 3 part 1 and part 2. There will be 2 elective blocks, that is each elective block is of 2 weeks duration. Previously it was a 1 month duration, later it was modified to 2 weeks duration. Block 1 electives are from preclinical departments, paraclinical, basic science laboratory, ongoing research project. Block 1, that is 2 weeks, and block 2 from clinical departments. And assessment of electives shall be included in internal assessment. So this is another new concept that was introduced by NMC as a part of the curriculum. Electives, it is of 2 weeks duration, 2 weeks plus 4 weeks. And block 1 is for preclinical and paraclinical. Right now the students of final MBBS part 2, they are in block 2. They are from 7th March to 20th March. They are now doing electives. After completion of the electives, and they will start their final MBBS part 2 program. This is another new concept that was introduced in the curriculum, sports and extracurricular activities, but this was only during phase 1 and phase 2, and no sports and extracurricular during phase 3 part 1 and part 2. Already you know that the duration of our MBBS course is 4.5 academic years. Previously it was divided into 9 semesters, now no semester system. It is only yearly based. We call it as a phase 1 MBBS, phase 2 MBBS, phase 3 MBBS part 1, phase 3 MBBS part 2. That is the nomenclature. Followed by 1 year of compulsory rotating internship, CRMI. And academic year means 39 weeks. Previously it was 240 days. Now it is 39 weeks is one academic year. And minimum is 8 hours per day with 1 hour lunch break. That is a study period is 7 hours. So this is the, based on this we prepare the timetable for our program. So first professional year will commence with the induction course, that is a foundation course, by 1st August of every year. That is the NMC guideline, but last year the program was started on 14th October. This year most probably the program will start on 1st August. Supplementary examinations will be conducted after the main examination within a period of 3 to 6 weeks time. Within a period of 3 to 6 weeks time, and even including the declaration of the results. Supplementary examinations and the declaration of results shall be processed within 3 to 6 weeks time from the date of declaration of the results of the main examination for every professional year. For second MBBS, already the circular was issued even before the results were published. So results had come after the notification of the supplementary examination schedule, and they will write the supplementary examination on 7th April. A learner shall not be entitled to graduate later than 10 years. 10 years is the maximum period the student has to complete MBBS course from the date of joining first MBBS. And in case of first MBBS, no more than 4 attempts shall be allowed for a candidate to pass the first professional examination. These are the new regulations framed by NMC under the competency-based medical education program. 10 years is the maximum limit, and in the first MBBS, the student has to clear all the subjects within 4 attempts within a period of 4 years' time. So this is the that is the time distribution of MBBS program, and the course was started on 1st September of 2023, applicable for 23 batch, and they will write the examinations of first MBBS in the 2024 August, and the second MBBS starts on September 2024. Third MBBS part 1 starts on, that is 2025 of September. Then the final MBBS part 2 will be completed by 54th month. So this was given by the NMC, but there is a delay in admissions. As a result, most of the times we may not be able to follow this. Already you know that in the first MBBS the courses are anatomy, physiology and biochemistry, and foundation course is 1 week, and introduction of early, that is a community medicine, will also be there in first MBBS, and there will be early clinical exposure during first MBBS, and the ADCOM module will be introduced in the first MBBS. So in first MBBS, these are the courses, the duration is 12 months, and they call it as university first professional. So foundation course 1 week, then anatomy, physiology, biochemistry, then introduction to community medicine, family adoption program, early clinical exposure, ADCOM. These are the new components that were introduced. That is a foundation course, family adoption program, early clinical exposure, ADCOM were the new components that were introduced in the curriculum. Same thing in second MBBS, ADCOM continues, and there will be family adoption program continues, and only 3 subjects the student will appear for the university examination: pathology, microbiology and pharmacology, and the duration of the course is 12 months. And in second MBBS itself, general medicine, general surgery, OBJ classes will be there, in addition to community medicine and forensic medicine. Whereas in third MBBS part 1, community medicine and forensic medicine, these are the only 2 subjects applicable for 3 batches, 2021, 2022 and 2023 batches, whereas a 2024 batch new regulations are applicable. So ENT and ophthalmology is a part of third MBBS part 1. Again, it is reverted. So during now 21, 22, 23 batches only they write community medicine and forensic medicine during the third MBBS part 1, that is the duration of the course is 12 months, whereas in part 2 they will write 6 subjects, that is general medicine, general surgery, OBG, pediatrics, ENT and ophthalmology. So there will be heavy burden on the student during third MBBS part 2. So this foundation course will be 1 week duration at the beginning of the first MBBS, but spread over 6 months at the discretion of the college to complete these hours. 160 hours is the duration of the foundation course. And the foundation course, it deals with the orientation towards the MBBS course, skills module, and field visit to community health center, introduction to professional development and ADCOM module, and sports, yoga and extracurricular activities, enhancement of language or computer skills. All these things will be dealt in the foundation course. In the first week, all 6 days will be on foundation course. The remaining hours will spread over a period of 6 months during first MBBS to complete all these programs. That is another concept that was introduced by NMC foundation course during, previously it was 1 month, but later it was reduced to 1 week and spread over a period of 6 months. This is the number of hours allotted for each subject by NMC, and you can see lectures and small group learning. Lectures in case of anatomy only 210 hours, but a small group learning is 400 hours. So 1/3 is the didactic lectures and 2/3 is a small group teaching. So now the concept of NMC is to focus on small group teaching. And self-directed learning is 10 hours, and the total number of hours is 620. So like that, for each subject, it is divided into lectures, a small group, and self-directed learning. And in addition to these 3 subjects, early clinical exposure will have 27 hours, community medicine will have 40 hours, family adoption program 27 hours, AdCom 26 hours, sports 10 hours, and formative assessment 60 hours. All put together 1521 hours is the study period during phase 1 MBBS course. It is same thing in the phase 2 MBBS. These are the hours divided into lectures, small group. Clinical postings is for a period of 540, and clinical postings shall be 3 hours per day. Monday to Friday there is a 15 hours per week, and Saturday there is no clinical posting, only for phase 2 MBBS students. Phase 2 MBBS students will have no clinical posting on Saturday. And the pandemic module was also introduced even in the course, but this pandemic module is withdrawn from 2024 onwards. This is a phase 3 MBBS part 1, where these are the electives. 156 hours is allotted for electives, that is a 4 weeks duration. Then general medicine will have 90 hours, surgery, OBG 90 hours. This is the theory classes, lectures, small group, and self-directed learning. And pediatrics 65, orthopedics are also there in the finals of part 1. And forensic medicine 130 hours, community medicine 145 hours, family adoption program 31, ENT ophthalmology 45 hours each, clinical posting again 540 hours, AdCom module is there, pediatric module. All these are the various components in the final MS part 1. These are the final MS part 2, general medicine, surgery, OBG, pediatrics, orthopedics, AdCom is there, dermatology, psychiatry, ENT and ophthalmology are also part of the final MS part 2, radio diagnosis, anesthesiology, and pandemic module. These are the various subjects that are in the final episode part 2. So this is regarding the clinical postings. 134 weeks is the duration of the clinical postings. In the phase 2 it is a 36 weeks duration, and phase 3 part 1 36 weeks, whereas phase 3 part 2 62 weeks. The duration of the phase 3 part 2 is 18 months, and 62 weeks is the clinical posting, and the total clinical postings is 134 weeks. So during clinical posting, the students in the phase 1, they were early clinical exposure, and whereas the phase 2 students, the concentration shall be on the history taking, physical examination, assessment of change in clinical status, communication, and patient education. Whereas phase 3 part 1 students, they will undergo training in all these aspects. In addition, they will choice of investigations, basic procedures, and continuity of care. Whereas phase 3 part 2 students, all this history taking and these investigations, basic procedures. In addition, they have to do decision making, part of the management and outcomes. So the training of a student in the clinical postings as per NMC is phase 2 concentrate on history taking, physical examination, phase 3 concentrate on investigations, basic procedures, phase 3 part 2 concentration on decision making, management and outcomes. First clinical posting in second professional year shall orient learners to the patient, their roles and specialty. Next, regarding the assessment, already you know, theory attendance that is required is a 75% attendance. Theory attendance is 75%, practical or clinical attendance is 80%. This is the most important in subjects are taught more than in one phase. General medicine, they will have theory classes in phase 2, phase 3 part 1 and phase 3 part 2. So in each phase the student has to maintain 75% attendance in theory and 80% in clinical postings. %75% attendance is mandatory in electives, and for third profession, part 2 in theory, 80% in clinical postings. So that is regarding the attendance criteria for eligibility to appear for the university examination. Another thing is the internal assessment. A minimum of 3 internal assessment examinations have to be conducted in preclinical and paraclinical subjects. Whereas in subjects taught in more than in one phase, internal assessment in each phase in each phase. So general medicine, there will be one examination in phase 2, one examination in phase 3 part 1, another examination in phase 3 part 2. So in each phase there shall be one examination. At least 50 marks, that is the eligibility, combined in theory and practical. Theory minimum is a 40%, practical minimum is 40%, but aggregate is 50%. That is the eligibility criteria to appear for the university examination. This internal assessment marks will not be added to the university examination marks. Internal assessment marks will not be added to the university examination marks, but the university examination marks memorandum will contain the internal assessment marks as a separate heading, as a separate head. So internal assessment marks also will be shown in the university marks card, but they will not be the part of the university examination marks. So minimum requirement is a 50%, minimum in theory 40%, minimum in practicals is 40%, but aggregate is 50%. Whereas this 2023 document says the internal assessment for theory is 500 marks and internal assessment in practicals is 500 marks, and you have to follow those guidelines given in this 2023 document. Whereas in 2024 document it has come for 100 marks theory, 100 marks for practicals, so it was changed. Regarding the university examinations, theory is the minimum 40% marks, paper 1 40%, paper 2 there is no such paper minimum. Both papers together the student must be able to secure 40%. Both papers together the student must be able to secure 40%. Practicals also the student shall be able to secure 40%, but aggregate shall be 50%. When theory and practical together the student must secure 50% marks. And MCQs will be there, 20% is MCQs, 80% is theory questions. Only one main examination in an academic year, supplementary examination within a period of 3 to 6 weeks time. So this is about the university examination criteria. So these are the paper distribution. Forensic medicine will have only paper, pediatrics only one paper, ENT and ophthalmology will have only one paper, 100 marks each, whereas the other subjects will have 2 papers, and the pass mark is a 40% theory, 40% practicals, together 50%. There is no paper minimum. Previously it was there, paper minimum 40% and pass mark is a 50%. That was the previous regulation. Now the present regulation is theory is a 40% and practicals is a 40%, but aggregate is a 50%, no paper minimum. This is that was about the CBME guidelines of 2023, applicable for 2021 batch, 2022 batch and 2023 batch. Now these are the guidelines for 2024 batch onwards. Now the students are in first MBBS and they will write the examinations in August, September, and they will enter into the second MBBS during October, and from we have to implement these guidelines for them. So this 24 batch, they started their course on 14th October of 2024, and they will appear for the university examinations in September, enter into phase 2 in October 2025, phase 3 October 2026, and phase 3 part 2 they will enter later and completed by 54th month. That is so the total duration of the course is 54 months. The first part, that is the first MBBS is 12 months, second MBBS is 12 months, third MBBS is part 1 is 12 months, whereas the third MBBS part 2 is 18 months. Previously second MBBS was 18 months and third MBBS part 2 is 12 months, and it was reversed. Now the second MBBS is only of 12 months duration, and the final MBBS part 2 is 18 months duration. This is applicable for the 25-26 batch onwards, where the admission starts on 1st September. That is 1st September is the admission for 2025-26 batch. So same thing, Only thing is ENT and ophthalmology is now part of the final MBBS part 1. Ophthalmology and ENT comes under final MBBS part 1. Previously it was in final MBBS part 2. Now it was reverted. Both ENT and ophthalmology, the students will appear along with the community medicine and forensic medicine. That is another modification in 2024 regulations. So the duration of the foundation course was reduced from 160 hours to 80 hours in 2024 regulations, and the duration of these 2 weeks at the start of the MBBS course. 2 weeks at the commencement of the MBBS. Previously it was 1 week and 160 hours spread over a period of 6 months. Now it is 2 weeks of duration and 80 hours is the allotted for foundation course. They reduced it from 160 to 80 hours in the new document. So there are certain changes in the hours in the subjects. In case of part 1 and that is phase 1, that is in phase 1 and phase 2 MBBS, there was not much modifications, whereas in phase 3, ENT and ophthalmology will come in phase 3 part 1, and orthopedics and pediatric classes will be there only in phase 3 part 2. Previously it was in phase 3 part 1. Now pediatric and orthopedic classes will be held only in phase 3 part 2. And the duration of clinical postings is 134 weeks, and electives 4 weeks, and general medicine 24 weeks, general surgery 24 weeks, and OBG 22 weeks, and pediatrics 12 weeks, community medicine 8 weeks, orthopedics 8 weeks, and ENT 8 weeks, and ophthalmology 8 weeks, and psychiatry is 6 weeks, and radio diagnosis 2 weeks, and dermatology 6 weeks, anesthesiology 2 weeks. Now this dentistry, there was 1 week clinical posting in phase 2 that was removed. So now totally 134 weeks is the total duration of the clinical postings from phase 2, phase 3 part 1 and phase 3 part 2. The same thing was already told. And this is only the difference is ENT and ophthalmology comes under phase 3 part 1. In phase 3 part 2, this medicine paper 2 contains medicine is the 50%, psychiatry 25%, and dermatology 25%. So the questions from psychiatry, there will be 25% marks in paper 2, and dermatology 25% marks in medicine paper 2. In surgery also, orthopedics 40% and anesthesia 10%, in radio diagnosis 10% in case of paper 2 of general surgery. So this was the, already I told you CBME guidelines, this was introduced. These guidelines will supersede the earlier guidelines issued by NMC. It will be implemented from the MBBS batch of 2024-25 onwards. So these are the CBME guidelines. 2024 will be implemented from, already implemented for 2024-25 batch. It will be implemented for other batches also. The previous one, they become invalid. So this is the comparison of phase 3 part 1. Already I told you ENT ophthalmology now is the, in case of 2023, it is only 45 hours because at that time it was part 2. Now for 24-25 batch, ENT 100 hours, ophthalmology 100 hours during phase 3 part 1. And general medicine, general surgery OB hours reduced from 90 to 60. So in case of phase 3 MBBS part 2, pediatrics 150 hours in 2024 batch, orthopedics 100 hours, ENT and ophthalmology there will be no classes for them. So clinical postings, previous guidelines, electives 4 weeks similar, general medicine had reduced from 27 to 24 weeks, and general surgery 21 to 24, OBG 21 to 22, pediatrics 13 to 12, and community medicine 8, orthopedics 8 weeks, ENT 8 weeks, and this is the difference between the previous 2023 guidelines and there were 24 guidelines, but total is 134 weeks, and the dentistry was totally removed. This is regarding the internal assessment marks of the 2024 guidelines, where the 100 marks is for theory, 100 marks for practical. In case of general medicine, this 200 marks, that is in phase 2, there shall be one examination, 550 marks is allotted. In phase 3, part 1, another internal assessment examination, 50 marks is allotted. And phase 3, part 2, 100 marks is allotted. And phase 3, part 2, 100 marks is divided. That is medicine 75 marks, psychiatry 13 marks, and DVL is at 12 marks. In the same way, for general surgery also, they divided into various components, and we had to follow these guidelines for 2024-25 batch onwards for calculation of internal assessment marks. Same marks distribution is same. 40% is the minimum theory mark, pass mark, and 40% in clinics, and aggregate is 50%. This is regarding the question paper setting. They have given certain guidelines where the scenario-based multiple choice questions, there shall be 10 to 20 questions based on scenario-based multiple choice questions. That is marks either 1 mark or 2 marks may be allotted. Long essay question, 1 essay question, marks may be 10 to 12. And reasoning questions, there shall be 5 reasoning questions. Each question contains 3 marks. And short answer questions, applied aspects 4. And carries 4 to 5 marks, and short notes 3 carries 5 to 6 marks, and short notes 4, 1 short notes is from ADCOM 4 to 5 marks. This marks distribution will be modified by the university, and the first MBBS question paper, once they appear in August, September, we will know the exact question paper pattern, but NMS had recommended that questions shall be based on clinical scenario, long essay question, reasoning questions, short notes applied, and short answers, and short notes like that. They divided in various components. But our university will decide what is to be adopted. So these are the suggested reading. Please go through these documents. This is of no use. And 2023 applicable for 21, 22, 23 batches. And the new regulations applicable for 24 batch onwards. Even competencies have been modified. So in 2024 batch onwards, competencies have been modified. In microbiology, previously we used to have 8 topics, now it was modified into 11 topics. So each subject competencies have been modified. So this 2024 contains new competencies. Please check this document. So I thank profusely the NMS Executive Committee on Faculty Development Program for this Thank you. So all these regulations are available on the website, and it is your choice to go through. But you have to implement all these guidelines.
Sir, open for Thank you, Dr. Kailasanath Reddy, sir. I think sir's documents is going to play a very important role tomorrow when you're going to draft a timetable. So because the distribution of phases, timing, hours, everything will be discussed in tomorrow's session, drafting the timetable. So this is the GMER element of the phases, time distribution, everything is very important when you're planning a timetable for your individual departments as well as for that phase of study. So you may think that it is just columns and columns of hours and dates, but all that is going to be put into practice tomorrow. So that is the importance of sir's lecture, right? Thank you. Okay, so now we'll go into the next topic, which is what I want you to please have a very, very thorough understanding before we plan the timetable. Okay, so this is called alignment and integration in CBME curriculum. Okay? So all of us are doing it subconsciously without knowing what we are doing. Sometimes it gets aligned, sometimes it gets integrated. But it's good, like, you know, our observer ma'am, Dr. Sarah said in the morning, how we don't realize that structuring a session becomes so important, so good for the faculty as well as the students. When you structure, when you align, when you integrate, the learning is far better. The so-called performance in the exam is far better, but actual product as a primary care physician is going to be much, much better that we are releasing into the society. So please keep that in mind, in that perspective, and then we will talk. It's going to be a long session, I'm warning you, okay? But we'll give you some break in between and some activities to keep you engaged. So this session, so-called, we are doing sharing, which we look what is sharing exactly. So I'm going to share the session with Dr. Kishore. Both of us are doing this session together, okay? Right. Okay, so before we get the technical glitch solved, I want somebody to tell me what is your understanding of alignment. Use that mic or I can give you the mic. We'll ask Kavya.
So basically, if we have the same topic being covered across different subjects, so we can put the timetable accordingly so that the same topic in all the subjects will come accordingly, like in the same. For example, if I'm taking MI in pathology, so the same topic, the drugs related to MI can be covered by pharmacology in the same week, or at least the same.
So excellent. So she is told very clearly, alignment means the similar topics across the subjects. We are all studied, we are all teachers, always subject-wise teachers. We are subject-wise experts. But you can make the learning of the student better if you align or you group all these topics in a particular timeline. Say the next 2 weeks, we are going to cover whatever aspects, cover or uncover, whatever aspects of ischemic heart disease. So she will talk in pathology about what are the changes in the cardiac muscle or whatever, what is happening, what are the enzymes that get elevated. At the same time, microbiology has maybe a little role only, not really, except when you talk about viral myocarditis and how it causes. It can present as MI, rarely, like COVID. So they can also have a role in that. So they can teach something to do with myocarditis during that week. May not be exactly myocardial infarction. Pathologists will look at myocardial infarction. At the same week or the next week, subsequent sessions, you can plan. The pharmacology department will talk about what are the drugs used in treatment of myocarditis or myocardial infarction. So that is brilliantly put. So topics that are similar topics, subject-wise, you spread it across a particular timeline so that the understanding of the disease, understanding of the problem is far better for the students, right? Okay, so now I want somebody to define what is integration. Anybody? Okay.
Integration is something when a particular topic is taught by different departments. Like, for example, thyroid disease can be taught by both medicine and surgery. So that is horizontal integration, and vertical integration is across different semesters or different, like first, second MBBS and final MBBS. So if you are teaching like pulmonary tuberculosis, microbiologist can tell about the microbiology aspects. The pharmacologist can come
So Shrikant has told us one of the ways of doing a integration. So basically what he is trying to say is, when I am talking about tuberculosis, maybe he's from internal medicine, right? So he's going to take class for phase 3, part 2 students on tuberculosis, right? So he is going to take the help of the microbiologist to come and take part of the session talking about the causative organism, right? And then maybe he will invite the pharmacologist to come and tell a little bit at the end of his session to talk about the ATT drugs. Okay, so that is precisely what me and Kishore are going to do in this session. It's called sharing. Okay, we'll look into all the aspects. So that is a very, very basic form of doing integration. There are other forms of doing integration. So what do you mean by, why do you want to do this? What is the idea? Because you don't want to take 1 hour lecture, you want 20 minutes, you give it off to somebody, 20 minutes, apada, I can give it to microbiologist. I can just relax, I'll make 5 slides and finish my class. Is that the purpose?
So So pathologist can deal, I mean, he can teach pathology in a better manner.
You think so? I can teach pathology better than pathologist. Okay, maybe you think the subject expert will be able to teach it much better than you, but as a clinician, you yourself can teach that part of pathology and that part of microbiology. What is that called? That is called nesting. We'll just look at it. You need a subject expert, but you are MBBS, no? You finish microbiology, pathology, pharmacology, anatomy, physiology, biochemistry. You would have got gold medal also in that. We don't know, right? So you are a primary care physician first. You are MBBS first before you did your MD internal medicine. So you yourself actually have the expertise to do it. But if you want real good, means somebody you think is better than you to do it, please do it. That is called sharing. But when you yourself do it, that is called nesting. Okay, I'm just waiting for it to start, so I have already into the subject, but we will again go through each of it. Anybody has got any other method of integration that you're familiar with? We'll share. What is linker case? Srinivas will tell us. If he tells that, my lecture is over. I'll hand it over to Kishore. That's it. Very good. Srinivas, please tell us.
So sometimes testing is also not possible. A test stretch to cover all those topics.
Okay.
You can keep case and so with respect to one case, we'll cover all this medicine, microbiology, pathology in that case itself.
Who will teach that session?
So that session will be can be taught by any faculty, especially if it is pharmacology means I will teach, because as you said, ma'am, we are MBBS graduates. Before that, we can slowly, step by step, we can cover it.
So what is the meaning of linker?
It should be linked to all the subjects. The case should.
So the case should have all the elements or all the various subjects that can possibly involved in that particular topic or particular disease. Yes. You use a case that will bring all those elements into it, and that is a linker case. Example
opioids.
Okay.
So it will be linked to, we'll put on case in such a way that it should be linked with drug abuse, that is psychiatry, pharmacology, as well as medical management in like opioid addiction with the general medicine.
Why not physiology and anatomy?
Physiology also, physiology, anatomy.
You need to know the neural tracts, you need to know the central nervous system,
true.
You need to know how the physiology of the brain works,
which
is the center, which will be triggering the opioid action.
Yes,
right?
True, yes.
Actually, you can do everything.
You can
even bring 12th standard science and 11th standard science if you want to.
Yes.
So that is the whole idea. Whole idea is that we are all thinking that at the end of MBBS, he is useless man. He has to do MD internal medicine. He has to do MS general surgery. That is not the concept. At the end of MBBS, everybody, I should be able to at least identify a basic psychiatric problem. I should be able to identify a basic surgical problem. I should be able to identify something basic in OBG. Okay, this person I cannot manage, I have to refer. I will also identify the problem and send the referral letter, so the OGCN takes priority on this case. I am suspecting eclampsia, I cannot aramse send the patient, I have to call and tell her, ma'am, I think this patient has got eclampsia, I am sending to your center, you please admit immediately and do whatever it is. So that is the role of the primary care physician. To make one doctor like that, we have to all work very, very hard. Right? Already you guys are working hard, and then we're making you sit through 3 days of BCME, 2 days of CISP 3, and then hopefully we are a little better in planning our teaching sessions so that the student benefits. Don't tell me students don't come for class. Doesn't matter. Whoever comes, we will teach very well. So that is the idea. So with that excellent definition already done by my colleagues, I think it's going to make it very easy for me and Kishore to take you through this session. Okay, thanks for your inputs at the beginning. In the light off pannilama. Right? So these are all copyrighted slides that we have got from NMC. We are allowed to modify it a little bit here and there. This is the original CISP2 which I have modified now. So always remember, whenever you take a class, kindly start with the objective slide. Of course, you put one nice flowery slide, something with your name, with all your degrees behind, all that is fine. The second slide should be the objective slide. So here at the end of this session, this marathon session I would say, participants will be able to define the terms integration, alignment and linker. All of you have done in your own way with very nice examples, right? And describe principles and levels of integration. Develop an aligned and integrated curriculum for phase 3 MBBS. We are sitting in CISP 3 today. And describe the stepwise process in developing and implementing a aligned and integrated topics, the so-called AITO, across all 3 phases, and to create a timetable and a schedule for AITO in phase 3 MBBS. So you have got a lot of very well-defined objectives for this session. So is that okay? Objectives are clear to you? Shall we proceed? Okay, so these are the terminologies that one need to understand. What is alignment? What is integration, which can be vertical or horizontal, as you all already very nicely said. And as Srinivas said, what is this linker case? Okay, so if you look at the definition, I am referring to GMR 2019 in this, but the latest, as sir just now said, is 2024. But the concepts of alignment, integration, everything remain the same through all the GMER documents. It has not really changed. So alignment is a grouping together in the timetable of learning elements from various subjects in a phase that can be grouped under a specific heading. We look at it either an organ system or disease. What Kavya gave an example was ischemic heart disease, myocardial infarction. So it's given a disease. That's how she's tried to align it. It could be organ system, means it will be the cardiovascular system. That's why I said you could include even myocarditis into it if you put it into an organ system. Then topics from other phases that are brought into a particular phase for the purpose of reinforcement or introduction will also be considered as integrated topics. This is what Dr. Srikanth was trying to tell, how to do integration. You bring in microbiology people, pharmacology into his session of internal medicine. You're sharing the session, you're bringing in from the lower phases, it's not lower or higher, for the phase that is already over, phase 1 and phase 2, you're bringing into phase 3. Likewise, in phase 1 only, I like to introduce phase 3 to the student. Like we do early clinical exposure, I would like to bring a clinical case to phase 1 students only to make them understand anatomy. I can bring a surgical case. So that is also, so when you want to introduce a concept in the earlier phase, or you want to reinforce a concept already learned in the later phase, both are called integration. Okay? Is that clear? Okay, linker is a session that allows a learner to link the concepts presented in an aligned topic through case discussions, which is what Srinivas was telling us. Okay, so what is the emphasis? Emphasis of learning should be competency-based, integrated, student-centered acquisition of skills, ethical and humanistic values. So we just had an exercise, what is the difference between the CBME curriculum and the traditional curriculum, with Dr. Padma took you through. So this integrated curriculum is also called SPICES. SPICES means student-centered, problem-oriented, integrated, community-oriented, electives play a place, and it's very systematic. It's also called the SPICES curriculum. So basically all these components are there. You also include acquisition of skills, ethical and humanistic values, that is your ADCOM module, okay, which we are going to have a session in the afternoon. Didactic teaching to be restricted to less than 1/3, okay. Lectures are less, greater emphasis is to be laid on hands-on training, symposia, seminars, all this you're already doing, small group discussions, problem-oriented discussions, and self-directed learning. And students must be encouraged to take active part in and shared responsibility for their learning, because they're supposed to be so-called adult learners. Adult learners means they take the responsibility of learning and passing the exam, and it's not the responsibility only of the teacher to make him or her learn, you know, this, with all due respects to NMC, the 60-40 rule, which confuses all of us. So it seems as though the onus is on the teacher. It's really not. The onus is always on the student with some contribution by the teacher, right? So the student should be able to take an active part and have a shared responsibility towards their learning and becoming a good doctor. Okay, so same, we're going to show a lot of colors in this talk. Okay, you're going to see all kinds of zodiac and this colors. So what is this? Traditional teaching. You see this yellow topics are scattered across the timetable in any which way. So that's why when we were discussing recently something, how to create an online timetable, how to keep it on a digital platform, you know, what happens is, today my topic in surgery is, I have to take the importance of blood transfusion and complications of blood transfusion. Okay, suddenly I find that I have to go into emergency surgery. I tell some other unit person, one assistant professor, please go and take my lecture. Okay, she or he is prepared to take carcinoma of the pancreas. So where is my topic, which is very basic? indications and complications of blood transfusions, because that is the level of learning. We are starting with basics in surgery, and suddenly you talk about carcinoma of pancreas, you're not doing justice to the students. Okay? So that is why scattered things, you try to, like we said, same phase you can get the topics across different subjects. It becomes horizontal, and you try to bring in other elements from other phases across the phase into your lecture. That becomes vertical integration. So to put it very simply, integration is the organization of teaching matter to interrelate or unify subjects frequently taught in separate courses or separate subjects or departments. So this is the one originally defined by Ronald Harden. Okay, so he's an educationist from the UK. I always tell in every meeting, I had the honor and opportunity of meeting him in person in one of the conferences. He's a very simple person, amazing person, but he has done so much of science and structure into medical education. Okay. Same thing, it goes on saying the same thing. Okay. Now, this Ronald Harden, he described this ladder of integration. So please watch this carefully. Each step has got one definition and meaning. You have to understand this before we proceed to the next set of slides. Okay. So the ladder is, we are the lowest when you're in isolation. That means everybody is into a silo or only subject-based teaching. The anatomy teacher doesn't even know what the physiology teacher is going to teach that day or next day, or whatever it is. They're totally oblivious as what is happening in the other department. They have this set of topics to finish the so-called syllabus. They want to go and finish within the time frame given. They have no clue as to what is physiology is doing or biochemistry is doing. Or if you take the phase 3 subjects, any of the phase 3 teachers, they don't know what the other teacher. That is totally in isolation. So it's a fragmented teaching. Like I said, no, physiology may be talking about CNS. Anatomy will be doing lower leg dissection and muscles of the lower limb. They are connected, but then the student doesn't see the connection at all, right? And biochemistry will be totally into Krebs cycle and all those things, right? So that is the isolation. What is awareness? You are aware that so-and-so is taking this topic in that subject, but you continue to take whatever you want to take. So that is awareness. Next step in the ladder is harmonization. You connect, you consult, but still continue your subject-based teaching. You may not really try to see that you're matching with the other department. The next one is nesting. This is what he was telling. Infusion with elements of other subjects. So when I am taking, say in general surgery, I am taking hernia chapter today, okay, or topic, whatever it is. So how do you think I should start hernia class? We'll ask Joshna. Yes, Joshna, you can tell us.
Basic by anatomy, ma'am.
Yes.
Anatomy.
Yes. So you start with the anatomy of the groin or you know, anatomy of the whatever, yeah, groin, then.
Pathophysiology. Like
what is that?
How does hernia occur? Hernia. How does hernia occur?
What is the mechanism that contributes to the formation of the hernia? Excellent. Then.
And clinical features.
Okay, clinical
Before
features.
That we have classifications and types of hernias.
Okay, fine.
Then clinical features.
Right.
Investigations, management, and complications of surgeries.
Okay, so this is the, okay, thanks Joshna. That is very nicely done. I hope all of us are teaching hernia like that. Okay, right. So nesting is now, as a surgeon, I am going to teach hernia. Before that, I need to recall or reiterate the fact what is the anatomy of the groin, what is the normal anatomy, and what are the physiological aspects that prevents hernia from occurring. You know, the shutter mechanism, the muscles, the placement of the superficial ring, deep ring, which differs in children versus adults, why it is different, what are the reasons, what is the normal physiology that prevents a hernia from occurring. That also I have to highlight. And what becomes abnormal is the pathology. So what all becomes weak, and therefore this person has developed a hernia. Then you go to the actual clinical material of clinical features, right? So that is nesting. So I am bringing an element of anatomy and physiology into a surgery topic which is phase 3. So I am doing it subconsciously. I don't even think that I am nesting, right? All of us are doing this. But this is what is meant by nesting. So you bring in, suppose I am doing pathology, somebody is teaching about some subject, I bring in elements of anatomy, I also show a case where this is how they will present in the surgery outpatient. So that is called nesting, is infusion with elements of other subjects. It's taught by the same teacher. The surgeon teaches, but the surgeon also talks about anatomy and physiology, right? So that is nesting. All of us are on board. If you want, I'll put on the light if you're feeling sleepy. Is it okay? You can see the slides, you're not sleepy? Okay, the most important which we do every day is temporal coordination. Temporal coordination along a timeline, what we said about alignment, that is only is alignment. That is, you different subjects teach a similar topic across a timeline of 2 weeks, say. What we discussed with IHT, the same thing applies here also. So that is temporal coordination. Sharing is joint teaching. I take part of a class, you take the remaining, the expert comes and takes the remaining classes, sharing. So sharing is the easiest to start off when you want to do integration. Next is nesting. Then temporal coordination, alignment is also easy. You teach only your subject, but somebody in the other subject will also be dealing with the same topic. So it is quite comfortable for us to do alignment, very easily we can do. Correlation, only areas of common interest you bring into that case. That is a linker case we said. Okay, we'll look into it. Then complementary is, I'm not even looking at pathology, I'm not even looking at surgery, I'm not even looking at, so it is only focus on themes or topics. Themes means, I'm going to teach geriatric medicine this week. Geriatric medicine has got so many components. Starting from anatomy only you have different things. Right? So it is a theme or it's a theme that I'm going to teach. It is not totally, the subjects are so many are involved, but the classes will go with saying the next 2 weeks classes will be take on geriatric medicine. You see, that is going at a very higher level, that is complementary. Next is multidisciplinary. Many subjects together, in the sense, multidisciplinary means I may ask a surgeon to talk, I may ask a sports medicine specialist to come and talk on hernia. So it is something beyond our basic subjects. We are going a little beyond. Interdisciplinary is loss of discipline perspective. So when I am taking hernia, I can even call a physiotherapist to take one of the sessions. May not be the same session, maybe some other session, and I am going interdisciplinary. That is, I will also have a nursing session on what nursing care should be for these patients, or how the nurse in the theater will assist me in a hernia surgery. So you're going interdisciplinary, and transdisciplinary is real world situations. That is difficult to teach. It has to be imbibed, it has to be observed. So that is not where we are at all. So where are we now, you think? What are the things we are doing now, we said? Nesting? Yes. This is the easiest. We are alignment. We are trying to share the same topics. Sharing, we are definitely doing. Correlation, I don't know how many of you are doing. Many of you will be doing using a case. That is one. We have to encourage and go to that level now. Beyond that, we will not focus. We will only discuss these 4 aspects. So what are the 4 aspects? Like in a class, I'm making you repeat, sorry. What are the 4 aspects? Nesting, temporal coordination or alignment we will refer to in our lecture now. Then sharing, correlation. These 4 things only we are going to concentrate. Okay, so this is what we need to really get the grasp of for us to plan our sessions better. So if you want to go back, this is how it sees in the NMC document, all the colors. Okay, so isolation is all separate. You are aware of what is going on. You try to harmonize a little bit, means try to discuss, but actually you're not doing anything. Then you start this nesting business, alignment. You share two subjects share one lecture. Correlation is by the unifying linker case. This and all is beyond us, so don't worry about all this. Okay, so I've given very simple. Horizontal integration is otherwise temporal coordination, otherwise called alignment. So don't get confused with the terminology. So if I want to align these 3 subjects across the face, one face only I can do alignment. Anatomy, physiology, biochemistry can decide this next 2 weeks they will teach CNS in whichever form they can. Whichever they have all these competencies, they will choose the appropriate competencies, make objectives, and next 2 weeks is a CNS block. So they will decide. Likewise, medicine, surgery, OBG, anesthesia. Can somebody give me an example? Because we have all these departments here. Which topic you think can be aligned between these 4 departments? Anybody? Quickly. Sepsis. Excellent. I was thinking of shock. You said sepsis. Good. So sepsis, actually anybody can discuss sepsis. Anybody can discuss shock. But it can easily be aligned. I can talk about all the topics, competencies on shock in the medicine curriculum you can teach. Surgery will be teaching all kinds of shock. OBG will have their own causes of septic shock. Anesthesia will tell us how to manage a patient with septic shock without asking for cardiology opinion. Who is anesthetist here? Anil is here, okay. Okay, right. So that means to say anesthetist will tell us about the management of septic shock. So if you take this next 1 week is going to be, or 2 weeks is going to be on shock block with a focus on septic shock, you can easily align across these 4 departments. You got it? So this is horizontal across the face. We are not going jumping phases. We are still sticking to phase 3 part 2, right? What is vertical? Now, I am going to same thing we talked about. So you can have anatomy, pathology, surgery, OBG, gyne. Tell me a topic. We don't want Shalini answering this question. Anybody can tell me? Vertical integration, any topic, anatomy, pathology, surgery, OBG, gyne. We'll ask the orthopedician to answer this. Ashish, can you answer? Okay, if you don't, that doesn't matter. Anybody? ARDS. Okay. You think how is anatomy involved in ARDS? Structure of the lung? Okay, maybe. Function of the lung? Yes, I. Okay, we'll think of ARDS. Excellent. I thought the same thing, and he has taken acute abdomen in OBG conference. That's why he remembers it so well. Acute abdomen, precisely. Anatomy, you need to know everything on the peritoneum, what are the structures, everything. And then pathology, definitely, what are the various diseases that can present as acute abdomen. Surgery and OBGYN. So acute abdomen in the pregnant lady, okay? Or pregnancy acute abdomen. That is one competency in your book actually. So you can nicely vertically integrate. Likewise, the other subjects, physiology, biochemistry, pharmacology, medicine. Diabetes mellitus, excellent. So you can have an entire 6 weeks of diabetes mellitus, because diabetes mellitus, I feel you need a year or more than a year to teach diabetes, right? It's such a vast, extensive topic. So that is, so basically, so when you integrate either horizontal, this is alignment, or vertical, you can either do organ systems or various other themes are there. I will tell you. Themes means no, don't go into that, but how can you do it? So you can have body systems. This is the most common model, cardiovascular system, respiratory system, genitourinary system. So this can be done very easily, integration. Or the life cycle, this is the most challenging. Life cycle means you start with genetics, start with embryology, start with normal anatomy, physiology, disease, clinical features, then pregnancy, childhood, adulthood, aging, death and dying. Very challenging, isn't it? We can still do it if you want, but it is one of the difficult models to design. Or problem-based or disease-based. This is what we discussed just now. Thematic is increasingly becoming popular, as I told you. It is like metabolic disorders, disorders of the elderly, or geriatric medicine. That's what I told you just now. Again, this is a little more difficult. Easiest for us would be which one you think? Body systems or diseases or problem oriented. What is a common problem or common disease, and you're trying to teach that alone, teach that in an integrated fashion. Okay, so so if you look at the regulations now, you will be wondering, my God, how am I going to teach the entire curriculum in an integrated fashion? Thankfully, they've been very kind to us. 80% you need to align it. That means temporal coordination. 20% only you need to really integrate. At least to start with, you can do 20% is the minimum required, so that the learning is better. So 80% if you want to do as a major method, 80% needs to be aligned. Allowed, same thing, similar topics in different subjects to be learned separately, but during the same time frame. Okay, is that clear? Anybody is sleepy can get up and do all the yogas and all the asanas and sit down again if you want. Okay, so this is one example, quick timetable I'm just showing. This is, of course, I have shown for phase 2, but you can interpret it and extrapolated to your own subjects. So if this is a whole from March to October timetable I'm showing. Pathology, in March we are starting, say, phase 2. Obviously, the first 1 month I will do general path and path, general micro, general pharm. Then you go to specifics. Again, I am doing inflammation, immunology, HIV. Here, micro, basically they can do only immunology, but they'll continue with general micro. Pharmacology will go into NSAIDs because we have inflammation. What is ANS, PNS? We'll ask Dr. Adiga. What is ANS, PNS? Very good, thank you. Autonomic nervous system, peripheral nervous system. Okay, thanks. Okay, May is again immunology. Like this it goes on. Then you start with CVS. All 3 subjects can do CVS, right? They continue CVS and then start hematology, 3 subjects. Then send up is your, maybe after 3 or 4 months you have this internal assessment or some exam is there. Vacation is there. Then they start respiratory system. Then they start genitourinary, GIT, hepatobiliary. See how nicely you can align it month-wise. So if you do this, what else are you noticing? We are covering the major chunks of diseases that you see as a global burden of disease or you see in your own community, right? These are the systems that normally have all these diseases. So basically you can easily chart. Alignment is actually not so difficult as you see. Any doubts in this till now? Okay. Okay, so regarding integration, as I told you, only a small portion, up to 20% you integrate, that is more than enough for the current guidelines. So this is where again we will look into some examples. So I said first is sharing topics. 2 disciplines may agree to plan and jointly implement a teaching program. Example is a topic like viral hepatitis can be jointly planned by pathology and microbiology as a single session. We already saw this. Sharing. 2 experts are coming and talking about that topic in the same class. They are from 2 different subjects, but only in 1 lecture they are going to deal with the topic. Then the nesting, which we already discussed, as much as possible correlates. This is correlation basically from other phases, not correlation, sorry, nesting. Other phases must also be introduced. So when you teach pathophysiology of cardiac failure, you should recap the structure of the heart, its function as a pump, loss of function in cardiac failure, while teaching pharmacophysiological actions of cardiac drugs related to restoration of cardiac function. So basically what we said, we gave an example of in hernia itself, how she looks at anatomy and physiology before teaching actually what are the components of hernia. So this is nesting. Okay, so I have just given an example. This is one complicated case. So quickly read it in your mind, or this is basically a 69-year-old guy who's brought to the emergency with sudden severe substernal crushing chest pain for the past 3 to 4 hours. He has nausea, excessive sweating, known to have hyperlipidemia, hypertension. He's not taking his medications regularly and he's quite sick on examination. Okay? So if you give a case like this to the student, okay, and you ask all these questions, okay, what does it say? What is your diagnosis based on this gentleman's history? What is your differential diagnosis? What are the key clinical features of this disease? What are the scientific basis for these features? What is the pathophysiology underlying these changes? What are your management goals and management options? Okay? So this is what you will like to question. But have you taught all these things is a question. Okay? So again, a basic principle of assessment in medical education is do not assess things that you have not taught or have not been taught, not by you exactly, by your department or by that phase teachers, whatever it is. So which competency you think you are dealing with? Something on? What is the diagnosis? Myocardial infarction. Okay, ischemic heart disease. So I am dealing with IM 2.4, which says discuss and describe the pathogenesis, natural history, evolution and complications of atherosclerosis and IHD. Okay, so what are the elements that I can bring into my class? I can bring in elements starting from anatomy, right? Importance of circulation, the coronary circulation. And then what is a normal conduction system of the heart? He's got some gallop rhythm and all on auscultation, right? So what is a normal system, conduction system? in biochemistry, because it says how are you going to diagnose and manage, what is your management principle. Only if you confirm your diagnosis you can treat correctly. So what are the enzymes, that cardiac enzymes, how does it elevate, how does it alter in myocardial infarction. In pathology, what is the macroscopic, microscopic changes in the cardiac muscle. Thankfully, we won't be doing a post-mortem on this guy. Hopefully, we'll resuscitate him. But one should be aware that can cause so much damage to the cardiac muscle. That is the idea. Okay, right? And in pharmacology, what are the vasodilatory effects of the nitrates, and what is the emergency drug that you're going to give him immediately before you even draw the blood sample. So the basis you can easily bring. So how will you bring it? Now I want somebody non-medicine to answer. How are you going to get these elements in your teaching of this competency? Quickly. Dr. Kishore, hopefully you're keeping time. I always tend to exceed, so you stop me. Okay. Yes. Somebody can answer this, take this question. How are you going to, what kind of integration are you going to use for teaching this competency? I've given you the case also nicely. I didn't make you sweat over and make the case. Multi? Vertical integration. Yes, vertical integration. How are you going to do vertical integration, I'm asking? Nesting. Okay, you can do it any which way in this. You can do nesting in a internal medicine class. You can bring in all these components. Pharmacology will be doing this with the same case. Anatomy, in fact, should do it with this case, anatomy and physiology. They should start their teaching with a clinical case like this. Otherwise, the students don't know why I have to read so much, so many branches of coronary arteries. What does it really matter? Why should I draw the diagram? Why this teacher wants me to draw all color diagram and give me marks for it? So when you start with a case like this only, they will know, if this artery is getting blocked, this guy is going to die. I need to know how it courses, what is the diameter, what are its tributaries, are there end arteries? I need to understand all these things if I have to save this patient. So that anatomy, they think, MBBS internship is so far away. Lot of time we can make up in the last 1 month before the exam. Now this doesn't work when you're going to treat a patient, right? So this is how you should start. So you can do all the types of integration that we just now discussed, starting with sharing, nesting, linker case correlation, anything you can do. Yeah, again, here when you're trying to, same thing. How do you do a linker? Example is teaching anemia and pathology. A case discussion linker session can help recap the normal physiology and pathology while linking to the clinical problem. So you can use, like I've given an example in anemia. So this is the guy. So this is the case. A 29-year-old male presents with weakness, palpitation, shortness of breath on exertion. Lab report shows hemoglobin was 8.5. Peripheral blood smear picture shows hypochromia. MCV is all reduced, mean corpuscular volume is reduced. So this is the case that is to link. What are the components? Physiology, pathology, medicine. How community medicine comes here? Can anybody tell me other than Mauna, how community medicine plays a role here? Prevention by, he is already anemic. How are you going to prevent this? What are you going to do? So you have to explain to this guy the importance of continuing the iron supplements. The community medicine hopefully will tell them what are the cheap foods available that is rich in iron. That is what they do, no? When they go into the community, the intern is supposed to tell them what are the foods that are iron rich, that is easily available, that is not very expensive. Don't tell, buy this yoga bar and have it once, thrice daily. That's not going to help the patient in a village, right? So that is the importance of linking community medicine. So community medicine can also use this case. You got it? When I'm teaching community medicine, I can use this linker case. When I'm teaching physiology only, I should start by using this case. Okay, so Dr. Kishore will show you how the linker cases works across the phases. So this is a way that you can use linker case to integrate very easily. All of us can do it. We're all primary care physicians, MBBS, everybody can understand this case and identify it. Okay, the same thing, again I like to show a lot of colors, it keeps on coming, sorry about it. Okay, but what are the caveats or what are the cautious words about integration? Okay, care must be taken to ensure achievement of phase-based objectives should be given primacy. I should not go overboard and try to make 60% integration and lose the focus of my own subject. Okay, so keep that in focus. Try to align the remaining subject, but try to integrate only 20%. Okay, topics that cannot be aligned and integrated must be provided adequate time in the curriculum and run as parallel sessions. You know, you have this miscellaneous, so-called miscellaneous topics in every subject, right? You don't know in which organ system, in which disease, which theme you want to fit in, but those also have to be taught to the students. So keep time in your timetable for non-aligned sessions. Assessment, unfortunately, remains still subject-wise, right? You write only subject-wise exams. You don't have integrated exams for that phase. So you have to keep that in mind and continue to do that. But you can also use little bit of integrated assessments in your formative assessments. At the end of the lecture, again, I'll come back to tell you about that. Time over, Kishore? Okay, so now listen carefully. This I want you to really be wide awake. Like Mr. Bean, if you want, I'll give you matchsticks to keep your eyelids open. Is it difficult? All of you wide awake? Right? So this is the essential steps all of us should follow if you want to do alignment and integration. Okay, so first of all, the first question is, can the competency be achieved together with similar competencies in other subjects? Okay, yes or no? You take your own phase. Don't worry about going forward and backward. You take your own phase subjects. Can it be achieved together? Or yes means we are going through at least next 10 steps. No is very easy. You junk them into the non-aligned slots in the timetable. Okay. Yes means choose one strategy for the aligned competency. Are you going to go organ system wise? Are you going to take a disease and teach it like that? That is, disease means it becomes AIT, aligned and integrated topic. That is some disease you're choosing. Then list the competencies in the AIT under the respective subjects in each phase. This Dr. Kishore will take you through the whole exercise, so I'm not going to elaborate. So you list all the competencies so that medicine, surgery, OBG, pediatrics is there. Suppose we are talking about cardiovascular system, I list out all the competencies, subject-wise you list it out. For each phase, review the competencies of all the subjects and reduce the redundancy. Redundancy means, which system I said just now? Cardiovascular? Okay, cardiovascular system, there may be something about cardiac failure in medicine. There can be a similar cardiac failure in pediatrics. There may be pregnancy with cardiac failure in OBG. Surgery, cardiac failure is very remote. Surgeons don't want to look at cardiac failure. We push them off into medicine, or cardiologists push them into ICU. We don't want to operate on these guys. So surgery doesn't enter the picture. These three subjects are there, right? So if you look at, so the most important thing is the competency has to be broken into objectives. So each department, if you devise objectives, the first objective will be define cardiac failure. That will be there in every subject. So you need not really repeat every time you're taking a class, define cardiac failure, right? So certain common objectives, you can decide only this medicine subject alone will take all those things. The rest of us in the week I'm not going to waste my time on these objectives. I will go on to my subject specific objectives. So that is called redundancy, means extra repeated ones, you try to prune it or cut it so that your time is very precious, right? So we won't waste time teaching the same things all over again to the same group of students, right? Then review competencies from other phases and mark which of these needs reinforcement or introduction in the current phase. So till now, what have we been talking about? We are talking only about alignment. We are looking at only the same phase subjects and thinking which and all, we can prune the objectives. Now you look at competencies from other subjects in other phases and mark which needs to be brought into your lectures. Then create learning sessions, write the objectives and the method of instruction. Then create a linker or integrator session which can integrate the concepts learnt in the whatever cardiovascular system. Then you allocate self-directed learning sessions, give assignments, you create formative assessment sessions at the end of each aligned session, include non-aligned and integrated also, and prepare timetable. That's all. All these things he will go through again. and ensure this non-aligned topics also get a part of your timetable. Okay, got it? Is it clear, these steps? Okay, it is given, don't worry, it is given in the CISP book that I have given it to you. It is there on the NMC website also. Please go through it again for reinforcement for us. Okay. So, same thing, we have been asking this question right from the beginning of my lecture. How are we going to align? What are we going to integrate? What are the steps involved? Okay, same thing repeats. Okay, so this table again is very, very important to understand. First you take the competency. It cannot be taught as part of a particular topic. Say cardiovascular system, it doesn't come. Then teach it separately. That is the non-aligned. It goes out of the basket, right? Then can be taught together in different sessions in the same topic means you align. Can be taught in the same session in the same topic. This is your nesting, integrate. Okay. Can be used to link concepts taught in a particular topic means this is a linker case. You are bringing in concepts from anatomy, physiology, using a linker. You can do that same thing in nesting also. So you decide how you want to do. So if it is the same phase, what do you do? If it is a different phase, what do you do? This also is given in your book. So please go through it and understand it. These two steps, this one, previous one, this steps plus this one. It should be very clear in your mind when you are planning your alignment and integration. Okay, let's start. So this is where I stop and Dr. Kishore will start. Thank you. Any doubts? Again, no claps. I'm coming back again. Don't worry. I will not go so easily. Okay. At the end of Dr. Kishore's thing, we will look at how to do formative assessment so that the integrated learning is assessed. Okay. Now, sir will take you through the actual nuances of to creating an alignment and integrated session. Over to you, Kishore. Thank you.
Good afternoon, all. Can say good afternoon back. Yeah, hi, thank you. Before starting the session, I'll just go through an example here. Before going for that, I just ask all the participants to stand a bit little. You can just stand. Come front of your table. Please just come front of your table. Come front of your table and stand as per your heights. Stand as per your heights. All of you come front of the table. Stand in front of the table and stretch your hands. No. Arrange yourselves to stretch your hands. I think a lot of space is there. You can stretch your hands. Stretch your hands. No. It should be like, there should be gap. Try to stretch and, okay. Now the task is, there is a small task for you. Come little front. If I say to make your right hand up, make your left hand up, not opposite you have to make. Okay, if I say to move one step front, you should go one step backward. Opposite. You have to do opposite. Okay, let's start. Ready? See, please be little front so that if I ask front, you should go back and then you should not fall. Okay. Nod your head to right. Nod your head to left. Nod your head up. Nod your head down. Sit. Stand. Okay, your right hand up. Left hand up. Right hand down. Yeah, thank you. Thank you very much. Please sit back in your tables. I think just got a warm up, right? Now, let's start with the topic. Can anyone switch off the light, please? Yeah. Okay. Madam has gone through what exactly are the terminologies that we have come across with various terminologies that we express it out in alignment and integration. And before starting up to understand what exactly it is, how many in this group, that is all the 30 participants, how many have actually, because we are going across these phases, how many have gone through horizontal integration? Or how many exactly have taken up the horizontal integration classes? 1, 2, 3, it might be with your same phase, it should be. So I have seen people from final year also, like in medicine and surgery. And how many have gone through regarding vertical integration? Yeah, quite a good. I think then probably you are being aligned and also integrated, right? Now I'll just take with one example here. The example here you can just see, that is PY 2.4 and PY 2.5. This is from phase 1 actually. This is regarding anemia. So alignment actually was taken up from, either it can be taken from the subject or system wise, an organ system, either it might be CVS or it might be what you call respiratory tract infection or respiratory tract, any system wise or otherwise disease wise. Okay, here we have taken an example from a topic or a disease, that is anemia. Now what exactly has to be done phase wise? For example, if we take phase 1, there is physiology, biochemistry and anatomy. In the same way, phase 2 you have all the other 3 subjects, and phase 3. Like if you take from each phase, so we need to understand, if we are taking the topic and identifying the topic as anemia here, I am taking anemia as an example and going through along how you go stepwise to align and how you go stepwise to integrate. Okay. So if you take anemia, now you have to go through the what you call the entire booklet of phase 1 in both anatomy, biochemistry and physiology. So what are all the topics that fit into this topic anemia? So take out those competencies up. Like for example, in physiology, 2.4 and 2.5 can be taken. And can the competency be achieved together with similar competencies in other subjects? You need to check, like in biochemistry and also in anatomy, whether are there any competencies that fit into. And apart from the same phase, you need to check the competencies that will fit into this from other phases also, like in pathology, microbiology and pharmacology. In the same way, internal medicine, pediatrics, OBG and other, wherever these competencies can up. So you have to pick all these competencies up. Like, so what strategy? Now, once you understand to pick up these competencies from each phase and each subject, and now what strategy for aligning? Choose a method, either in organ system or disease. Either you can take this across like a CVS system or otherwise a blood or otherwise you can take across the topic wise. Like for example, here the topic, they have identified it as a topic and they have taken the topic as anemia. Now the same thing they have gone through in phase 2, like in pathology, for example, in 13.1, 13.3, 13.4 and 13.5, and they have taken it from phase 2, and now from they have now what they have done is alignment has been done, like the list of anemia specific competencies from pathology, from pharmacology, from microbiology have been listed out. This is what exactly how. For example, if the topic is being, though it is being taken in phase 1 or in phase 2 or in phase 3. For example, if pathology people are taking the alignment of anemia, so they have to just go through the other subjects also, like pharmacology and microbiology, and they have to take up all these competencies. Okay, they have to take up all the competencies, and now once you take up all these competencies in each phase, in the same way, you can take up the competencies from phase 3, like from internal medicine, from pediatrics and from OBG. All these competencies will be taken up, and now what has to be done is what madam has told. Like for example, if you wanted to do phase-wise alignment, like phase 1, like competency 1, 2, 3, competency 1, 2, 3 from each subject. This is one subject, this is another subject. In the same way, phase 2, this is one subject and this is another subject. The color coding differs you, what subjects, and then the competencies. So a temporal coordination will be made, what you call it as from phase. From each phase, you parallelly teach the same thing. For example, if you are teaching anemia in pathology, the same topics will be parallelly taught in microbiology, and the same topics like from anemia will be taught in that particular week kind of thing. Okay, so this is what exactly happens in temporal coordination. We have chosen the topic to teach subject matter in the same phase together, and we have listed all the subject competencies that fit into the topic phase wise. This is what we do in temporal coordination. And then for each phase, now what we have to do is to review. So we need to review the competencies. What are all the competencies are there? If there any redundancy is there. So now we are actually planning to sit and set together between the subjects to see that redundancy is not being happening. Okay, redundancy is nothing but the same topic is being repeated in different subjects, and unnecessary wastage of time and hours will be there. Now, so in order to remove the redundancy, what you need to do is you need to sequence out. You need to sequence out the topics. For example, this is pathology, this is microbiology, and this is pharmacology, and again pathology. See, you can see the sequence of the topic should go. Like, for example, if you are talking about anemia, so describe the hematopoiesis and extramedullary hematopoiesis, define and classify anemia. All this will go, and then finally the total topic will come. When you align all these things and keep the sequence accordingly, the competencies, you will come. So who has to teach first, and which subject has to be taught first, and which subject has to come next, so that you can make a sequential order of the particular thing. So the same thing here, they have now derived the learning objectives. So we have taught previously in BCME, we have derived the objectives for the competencies, right? So with the ABCD rule. So now for each competency, now you have to derive the objectives. So you have to have a clear-cut objectives. And then, for example, it is the first thing here, define and classify anemia. For this, these are the objectives: define anemia, classify anemia. All these things you have to give the objectives for each subject. Okay, so now for pathology, they have derived the objectives, and for microbiology and for pharmacology, they have derived the objectives. Now these objectives are being aligned. So you can see objective 1, objective 2, like that. When you align them and then keep, so probably you might get either to share between the subjects. The alignment will help you to share, which you call it as sharing, and otherwise you can remove the same things that are being there and then make an integrated part of thing, which you call it as a vertical integration, or otherwise a horizontal integration if it is in the same phase. If it is a vertical integration, it is across the phases. Okay. So bunching of the same things are being done, that is nothing but the objectives are being clearly defined. And then now what exactly you do is, so you make a lesson plan. So you have to make a lesson plan, and then it has to be taught. If it is phase 1, if it is teaching, so it all depends upon which phase to the student, which phase students you are teaching. It should be either from the already taught ones, and otherwise the future subjects that are going to be taught has to be linked in, and a linker cases also can be added, which I'll just add it. So you need to do a sharing, a correlation, nesting, all has to be integrated, and you need to prepare a appropriate lesson plan. Okay, so now what exactly this sharing? So I said that integration. So alignment, once the alignment of the topics are being done with the competencies, now how you are going to integrate it? Like either you are going to share it between the subjects, or otherwise you are correlating it, or otherwise you are nesting it. Nesting, actually the same person will teach, but he will be taking the necessary inputs from the either pre or paraclinical, or otherwise the subjects that are being taught next. So for example, if I say an integration sharing, so you need to review the objectives. So you need to go through what are all the objectives that are there from different subjects of the same phase, and see if they can be shared to reduce the redundancy. You need to see that whether you can do any redundancy and to increase the correlation of the topic, so that you can just have a look of phase 2, subject 4, and phase 3, subject 7 or something. So the same topic is being redundant. Please remove those, and then either at appropriate time one can teach. teach. So that if you derive the objectives and come to know exactly what you are going to teach, then it will help you out to remove that particular things and then align in such a way to tell the topic so that redundancy will not happen. In the same thing, this is what you see. The same thing actually is being taught where it is being across the phases. And now, a single learning sessions where you can see the single session created by bunching of subject-specific objectives and single session created by sharing of similar objectives between two subjects, between two different subjects or between in the same subject, bunching of that particular specific objectives can be done as such. Between like you can see this is between subject 5 and subject 6 and this is between the same subject. And review all these where you do for nesting. How do you do a nesting is, review the objectives from other subjects from phases to see if it needs to be added to the learning sessions. So if as a microbiologist, if I am telling about something like anemia, so I need to see the subjects from other phases or the subjects from the same phase so that I can take the inputs of that particular thing and then I can add to it and then tell accordingly. This is the same again. I'll just show an example here. This is a correlation. Choose objectives from a different phase and can be used to link by using a linker case. So you can see here correlating the same thing. So I'll just show you in phase 1. So these are the same topics that you are going to tell, and here in the phase 2 and again in phase 2, and then now you link up between phase 1, phase 2 and phase 3 and then put a linker case. An example here is being given, and what the linker case here is a child with iron deficiency anemia. So you are taking a case of child with iron deficiency anemia and then you are linking the same topic across, like it is in the same phase and between the phases, and also linking up with the case and then discussing about the topic. Okay. So all these now you need to prepare a session, like an integrated session with a particular case scenario, and then you need to say across the phases, like phase 1 and phase 2. In the same way, for a next higher level, if you are talking taking the class for the phase 1 to be introduced early. And for a previous phase, if it is in between phase 2 students, so previously taught a topic in phase 1 and 2, like for example, madam said about hernia, so where anatomy of the anatomy site and then the muscles and then the physiological aspects of it has to be taken, and then the same thing will go for the phase 3 also. And now I just, all these are same. This is actually, if at all the same case is being taught in phase 1, phase 2 and phase 3, now what you need to do is, you need to identify the common threads. So where the common threads are, and then you need to link across where you will be telling about the vertical integration. Same thing where you need to add with what you call the linkers, like clinical case scenarios. For example, anemia, there are many causes for anemia. So you need to take different case scenarios and different cases. For example, this is one case scenario in phase 1 where you can explain, and this is another case scenario where you can explain in phase 2, and another case scenario where you can explain in phase 3, and you can link up all these as a vertical integration. For example, I just have an example, you can just see. So look at a vertically aligned document of an anemia. What are the common problems that an Indian medical graduate should learn about this anemia, have to solve at a first contact physician in the community with respect to the disease. So you need to list out all different causes that can cause anemia, like anemia in children, pregnant women, elderly, polytrauma. To what degree of complexity can they solve the problem? So how they can solve the problem, like recognition, evaluation, management and referral. And now you need to prepare a case scenario. Like you need to prepare an infant with repeated blood transfusions, anemia and jaundice, a pregnant woman with iron deficiency anemia, an elderly alcoholic with GI bleeding, and a patient with polytrauma and acute blood loss, pre-operative and post-operative management. All this like this, you need to prepare the case scenarios. And then cases should be addressed objectives from the various phases from anemia topic. And then parallelly with this, you need to link up. So those linking of the cases has to be done. And then you need to thread it up and then make a scenario. I think before this, I'll just show the tables, madam. PDF. 22 page number. Chinchar. Close. Yeah, before exactly how we get that PDF, actually I wanted to show the document that is being given by NMC, that is Alignment and Integration Module. You can just go through the website, NMC website, and just go through the alignment and integration module, clear-cut module is being given. So I just wanted, before going to that, I just wanted to ask you, like what exactly madam has said, what all the topics, I think few have done alignment and integration. What topics have you done with that alignment and integration? I think Sai Teja has lifted the hand. What is the topic? Jaundice, like hepatitis, right? Hepatitis is one topic. Thyroid problems, right? Any other? Tuberculosis? Yeah, I think microbiology has integrated with tuberculosis. I think recently we have done with pharmacology. Pharmacology people has integrated with tuberculosis topic with pathology, microbiology, community, apoptosis. Apoptosis with pathology, yeah, good. This is actually the document. I'll just show you how it has been derived. You can see a comprehensive, so this is really a case of anemia, it has been taken up. So a comprehensive list of competencies for the topic anemia has been taken up from the competency booklet, that is whatever the booklet that you have. For example, for AITO in step 1, identify relevant competencies in each subject in the phase that can be taught in a, can just scroll up, in a temporarily coordinated fashion. I think this is better, this is okay, I'll just read out. Enlarge cheyagala. No, go up. Huh.
You want the previous one?
Huh.
You want to show the first one?
Yeah, this is the one. No, this is step 2. Go down. This is koncham paikil. So, yeah, madam. This is phase 1 competencies from anemia. So one is from physiology and one is from biochemistry. It is from different subjects they have taken. So describe and discuss the synthesis and function of hemoglobin and explain its breakdown. Describe the variants of hemoglobin. This is a know-how domain. And then in the biochemistry, they have 2 competencies there. So in this example, 2 related competencies are identified from physiology, which are in purple in color, and biochemistry, which are green in color from the competency booklet. So they have taken up from the subject, that is from physiology and biochemistry, from anemia, they have taken up the competencies. Please, can you scroll up? So now what they have done here is, they have now derived from this competency the objectives. These are all the objectives that they have derived, and in the same way from the biochemistry, the objectives that they have derived. So how you need to go for an alignment integration? First take the competencies for that particular topic which you are going to tell, and from the competencies derive the objectives. Next. Because why I am just showing you is, you have an exercise to be done. So if you want to go for alignment and then to do it, deriving an objective, which we have taught exactly in BCME, is a keynote where you need to understand and you need to have objectives. Why? Because the redundancies and all will be removed here. See, you can see here in the third step what they have done. So, they have looked into which are the objectives that can be shared between the subjects. This is a sharing between physiology and biochemistry. So, the same thing where these are the cross lines where you are seeing. And now here the merging objectives into a shared session. Now they have merged both from physiology and biochemistry, and now they have made a lesson plan in such a way so that the redundancy will not occur, and then they have shared it across physiology, biochemistry, and pathology also comes here where they link up with the vertical integration. Just move up to the next step. Yeah. Here actually the pathology also has come, which is where they undergo a nesting. If needed, identify the competencies from other phases for vertical integration. Please just go a little bit slow. Koncham paiki. If desired subjects from other phases are being reviewed for competencies, that will enhance the value of learning. If you think that this will give an input for the students, a more value to it, in this instance, a few competencies from pathology are being brought to phase 1 to enhance. So, the topic actually is from phase 1, but they have taken the phase from pathology, phase 2 also, so that it will help the students to learn more or to understand more, to enhance the value of learning in the shared session. This is called as exactly the nesting part that you are doing. Next. So, the topic will be dealt with either physiology or biochemistry, but pathology inputs also being taken. Now, identify the suitable objectives that will enhance learning in the session. So, you need to identify what are all the objectives that will enhance the learning. Can you just scroll up? So, objectives from the pathology, brown, are being listed out, and these topics are being taken. Go up. So, now what they have done in the lesson plan, so the pathology, these brown ones are nothing but pathology. You can see the pathology topic has gone up now here. So, clinical features of sickle cell anemia, and you have what you call the regular topic that is being taken and pathology is being added, where the lesson plan, when you are preparing the lesson plan, nesting is being done in such a way so that the sequence will go accordingly. Next. So, now create a lesson plan based upon the shared and nested elements, and you get the entire both physiology, biochemistry and pathology put together all. You can get a good a lesson plan so that you can teach accordingly. A lesson plan is created for an integrated. So, this becomes now as from the alignment it becomes an integrated session now. Next. Yeah, if needed, if at all you want to take a case, a linker case up, and then or correlate with any of these things. So, if needed, create a paper case with presentation, diagnostic indices, etc. to allow students to explore in a small group discussion. You can make a small group discussion, and then a case will allow students to correlate and learn better and provide the necessary relevances, which we call it as a correlation. And this actually is nothing but a linker kind of thing that you are adding in between. And almost you can make a session in such a way to make as an SDL class also in between. Next. That's it. This is the other thing. Yeah, now you need to understand how when this is being prepared, like you prepare a lesson plan and take an alignment integration. So, after finishing an alignment integration, you need to understand how you are going, you need to give in between assignments, and then you need to know or understand how you assess the student, like you need to know various methods for assessing the student and assessment methods that you can make up to understand the alignment integration that is being done. And this assessment part will be taken up by Madam again. Please, Madam.
Thank you. Nice. Well done. Go to slide number 55. 55. Okay. Are we all okay? I'm not going to do any games like Kishore did. So we just get on with this. So now that I think you've got a fairly good idea of alignment, various aspects of integration. He's given very good examples. He's run through the anemia component in 2 different ways to show you exactly how to go about. Okay. So sometimes alignment integration is like taking a class in statistics. At the end of somebody's biostatistics class, you think, perfect, I know everything. I know which test to use for what. I know which type of study I will design. 2 weeks later you ask, no? I have to go call statistician, I have to run to community medicine department. So how will you retain this? By starting to do it right today only. You can just do, I'm going to give you exercise anyway. For the job, I'm giving group work just now. If we have time, we'll finish it. Otherwise, you'll post it on the group by tonight. Okay, so you have to keep doing this activity, exercise in your day-to-day planning in your department, and definitely you'll be master at it. The next CISP, I may invite one of you to come and give the lecture with your own example to run through, so that you know what are the challenges, what are the practicalities, and it will be fantastic if one of the faculty can come and deliver the session for me. Okay, so just remember that now everything seems crystal clear. Tomorrow you may be a little fuzzy, but start doing it tomorrow, then you will definitely get the hang of it. So now having aligned and having done about 20% integration, now how do you know, like, always we think we are brilliant teachers, but then we look at the test marks, we are depressed because the student has not passed the test, right? And it may be your fault, his fault, both the fault, we don't know what it is. So if you want the learning to be better, how do you assess whether they have learned in the integrated fashion that you have taught? So how do you do formative assessments for these aligned sessions and integrated sessions? Quickly we'll look at it. Okay, so again we are stuck with anemia today, so it's okay. So you have to first identify, like any assessment, what is a domain that particular objective or competency essentially deals with. Competency may deal with many domains. It could be knowledge, skill, attitude, communication. But any objective that you derive or a set of objectives, you decide whether it is the knowledge domain or is it the skill domain. Depending on which domain, you plan the test, just like any other session. So if you look at this, you are talking about linker case 1, describe the composition and functions of blood and its components. It's basically knowledge domain. So you can have a standard assessment will be written or viva. But if you want to really use the linker case, then you can tweak it a little bit in your formative assessments. You can have a case resolution, you can have a case-based discussion, you can even have a viva on the case. Okay, let's look at it. If it's going to be skill, it's going to be using reflection, practical labs, OSCE. Like example is visit to the blood bank. It is a skill in the sense it's a physical skill. You go and observe, thinking skill. How are you going to assess it? Once I had a student logbook. Today morning, I went at 9 o'clock to surgery ward, did rounds with chief, had a tea with them, had lunch with the PGs. Afternoon, wrote discharge summaries, went home. Arey, what did you learn today? What did you effectively do? It's not reflected at all in that. So I don't know whether he or she has learned a skill of catheterization that day or learned to write a prescription properly that day or a discharge summary that day. So it doesn't really reflect. But sometimes something abstract like visit to the blood bank, you should give certain objectives. When you visit the blood bank, I want you to observe this, this, this. I want you to make a note of this. I want to make a note of this. See how one blood cross match is done, and you please give your reflection on that. So if you have to give objectives, this we say with even early clinical exposure. Somebody is going to talk to you in early clinical exposure today afternoon. You have to send the students to the clinics with an objective that should be known not only to the anatomist who is sending, but also to the physician sitting in the OP there. With what objective these students have come, then only they will learn something. Otherwise they'll say, oh, I went to the OP was so crowded, it was smelling so much. I felt faint because it was so hot and I came back. That is a reflection in the logbook. But they have not observed or learnt anything. So be very careful in trying to find out what you're trying to assess. That should be very obvious. Okay, so integrated assessments, like I told you, can be case resolutions, can be assignments. There is something called integrated MCQ. I'll show you a couple. Structured essays, short answers, or your integrated OSPI, OSCE, or reflection. So here, example of formative assessment case resolution. These are the competencies in physiology and pathology about erythropoiesis, hematopoiesis, extramedullary hematopoiesis. So you have a small group discussion, you have a case resolution. So you discuss a case which goes like this: a 3-year-old toddler presents with recurrent pallor, jaundice requiring recurrent blood transfusion since birth. The blood group of the child is O positive, child clinically has hepatosplenomegaly, and these are the lab values. So the lead questions is what is happening to this child, what normal physiology is deranged. So a set of questions that will make the student think in groups, need not be individual student. They sit and thrash out these questions and try to answer and try to resolve what is a diagnosis in this child and what are the problems and how are you going to alter it. So this is formative assessment in the format of small group discussion and case resolution. So you have a way of marking the students, how each person contributed to each question or did they discuss. So you mark them and give individual marks to students. This is case resolution. Reflection, as I told you, visit to the blood bank. Write a reflection on blood bank functions and significance. You are given something specific to reflect on, not on the location, on the infrastructure, all those things. So this is how you do for a visit to the blood bank when you want to assess both physiology and pathology component on compatibility testing, blood grouping, blood banking and blood transfusion. Okay, the same thing is repeated. Then if you want to do short assignments you can give. Discuss iron metabolism. I'm sure all of you are giving this, but it has to be corrected. Okay. Then an integrated MCQ. Now this is interesting because the standard MCQ will be just capturing the knowledge component, whatever it is. Now you're giving a clinical problem. This is called the problem-based clinical problem, and then you're trying to ask them the MCQ based on that. So these are the competencies that are involved that you're testing by using this one integrated MCQ. You're testing so many competencies. Look at that, because you're not only testing knowledge on pathology but also physiology and maybe pediatrics also. Okay, so this is a 6-month-old infant who has been fed exclusively on cow's milk, has the following parameters: hemoglobin 8, MCV is 60, and a peripheral smear picture of microcytic and hypochromic red blood cells. Which one of the following is a likely cause? You think this MCQ is correct? What is the answer? Any specialist, pediatrician, internal medicine? Naveen? Iron deficiency anemia. Okay. That is okay, but is it related to exclusively fed on cow's milk? Yes? Okay. So it has to make sense, right? So then they have to understand what is iron metabolism, what is the normal hemoglobin RBC indices, because the MCV is also given, the hemoglobin value is also given. It's a very simple integrated MCQ that is trying to integrate knowledge of pathology and physiology into this case. This can be kept in the pediatrics department as part of their formative assessment. So you are actually trying to bring in components from earlier phases and you are assessing. So the answer should be straightforward and the problem should be described in such a way that there will be only one likely answer, there is no confusion, and all these components from the previous phases are being assessed in pediatric posting or during pediatric curriculum. Okay, is that clear? All of you are with us, with me? No? Okay. Okay, structured essays. Structured essay, it is better to write, instead of describe the components of blood, that is standard. Structured essay should be a clinical based problem. So a 2-year-old child presents with pallor, whatever, and hepatosplenomegaly, discuss a pathophysiological basis of this condition. So in this you don't give the diagnosis. Many times you find that structured essay you give, and then you ask for differential diagnosis and explain everything about one disease. So the student knows only one disease, he'll just mug it up. He won't even interpret the case properly. So it is okay to take them to the higher level without giving the obvious diagnosis. They have to diagnose and they have to write the explanation for it. Okay, short answers is similar. Okay, something called integrated OSP is there. I don't know how many of you have done it in pathology or physiology or whatever it is. Here you give a clinical case. This is the peripheral smear of a 2-year-old child with pica and a hemoglobin of 6 gram percentage. Describe the RBC in the peripheral smear and which other RBC indices will you order as next step in the evaluation. Or I will in fact ask them to describe the RBC in the peripheral smear. So you can give this again in a pediatric posting, you can give this MCQ. So you're making them understand or recall the basic normal physiology and what is the abnormality here, and also what are the RBC indices that you need to have along with this to make a definitive diagnosis. So this could be an integrated OSPE where a peripheral smear picture is given to the student, and this OSPE station, they have to answer these questions. Similarly, in integrated OSCE here, a pregnant lady who has come with an antenatal checkup, you are going to ask them to recognize features of anemia. So this is a OSCE station with a checklist. Okay, so this already Kishore has told you. Right, now quickly I'll take you through how to do alignment and integration. I have taken my own example because this is phase 3, it's CISP 3. I thought we should show one clinical example. Then after that I'll give you your group work. So still quite a long way for lunch. So don't think lunch is around the corner. It's going to take another half an hour to 40 minutes for lunch break. You have to work and earn your lunch today. Is it okay? However bad or good the lunch is, right? Okay, so I have taken this competency in general medicine, right? So general medicine department has to teach this competency to the phase 3 part 2 students. So it says describe and discuss the epidemiology, microbiology, immunology and clinical evolution of infective viral hepatitis, and these are the details already given in your NMC curricular volume. If you have downloaded it, you will notice. It will tell you what is a domain, it is a knowledge domain. What is a level? It is a nose level. It is a core or non-core. Yes, it is a core topic. How do you teach? You can do lecture or small group discussion. How do you assess? He is also given how you can integrate it. So it's a ready-made document. All you need to do is break down the competency into objectives and decide how you want to integrate or align it. Very simple, because all this ideas is already given. So if you look at it, so he says vertical integration with pathology and microbiology. Okay, so first of all, the first step, the key step always is, this job we have to do. This the NMC has not done it, because somebody, I remember when I was in Ramchandra, lot of other college faculties will say, ma'am, if this ready-made objectives is there, no, you please share it. It solves my problem, I can go and do the timetable. I said, unfortunately, we don't have ready-made objectives. Each department has to slog hard, work hard, and make the objectives which they think is feasible and correct for them to teach. It depends on individual, some departments, some colleges may not have certain facilities. Like if I want to use a smart board, I don't have a smart board. And I would have created an objective in such a way that I can teach using only a smart board. Now how can I share it with another college? It doesn't make sense. And it's always better, the teacher who teaches should know what objectives they want to write. So this is the most difficult step. I want you to quickly look at this, and I want your expert comments on these objectives that I have written down myself. I didn't take any medicine person help. I have broken this competency into how many objectives? 8. Quickly criticize this. So what is a basic dictum in criticism? Anybody can tell me principle of criticism? You're going to give me a sandwich now. Okay, Vijeta is going to serve me a sandwich, hopefully a vegetarian one. Yes, sandwich technique na enna? Yes, Vijeta? Constructive criticism you should give. So what should you give me first? The nice part, be nice to me and say what is good about these objectives, if at all anything is good. And then what is lacking or what can be improved, quickly tell me. All of you are reading it. I will not get hurt at all. I got a skin of a rhinoceros, so don't worry. Ha, excellent. So he says, you have not brought in phase 1, anatomy is very important. Okay. So, okay, I don't know how many medicine people teach anatomy, but still, yes, it's a point that normal anatomy of the liver also can be visited during this very important thing on viral hepatitis. Very well. Point taken. Anything else? Hello, all of you are hypoglycemic, or you don't want to, I'll keep quiet, madam, I'll go to the next slide. No, I won't go to the next slide. Yes? Huh? That you are going to do, man. I have just put objectives. You have to tell me. What integration you want in this? What other objective you want? Yeah, integration means you want some other objective. Which is missing? Like he said, anatomy is missing. I agree. Physiology also. Function of the normal liver cell structure. Agreed. Very good. Anything else? Something very striking. Huh? Pathophysiology. Causative factors have written. No, that is pathophysiology. Modes of transmission. Yes. Excellent. So the community medicine part of it is missing. Excellent. Means follow-up advice. It can be done by general medicine only. I understand. Okay. So vaccination and prevention and whatever aspects. Excellent. Yes. Yes, Sai Teja. What do you want in the AdCom? You tell me an objective, man. The same thing about the importance of vaccination. So you can have a counseling session where your hepatitis B now, you have to make sure your family members are vaccinated and to prevent. And how do you keep, if it's hepatitis A, how you should isolate this person, make sure he doesn't spread the infection to the remaining household members. Yeah, correct. Okay, excellent. Very happy you're getting all this. See, everybody is subject specific. Pathology you have not given, madam. What is this? Yes, pathology I have not given it. But I have written something about causative factors, modes of transmission, immunology also comes in pathology, comes in microbiology. Yes. Okay, you can take more things. So you have to decide what are the other things you can add. What is striking to me, even though if you go one slide ahead, I said the whole competency is what level is only knowledge, but it's up to us. You can include attitude, skills, communication. Where is the objective for skill? Is there anything for skill? Okay, so I have done only knowledge domain. It's very easy for me to assess this student. But we should also come, like you said, communication, the ethical aspect of it, attitude, skills also. I can make objectives if I want out of viral hepatitis. What skill I can make? Interpretation of a liver enzyme report or a microbiology report which talks about whether the hepatitis B positive or negative, HCV. Anything else? Huh? Okay, subject expert, okay, antigen levels. Yeah, correct, absolutely. Interpretation of a report regarding this, either the infection or the liver enzymes or the liver function. Yes, exactly. That could be one skill. Any other skill? Huh? Sorry, Naveen? Physical examination. Okay, excellent. Of hepatomegaly, tender hepatomegaly, all those things will be there. Anything else? So we have talked anatomy, we have talked physiology, we have talked pathology, maybe a little bit of community medicine. So many subjects are there. Vaccination already she's touched upon, yes. Pharmacology. There, describe the treatment of viral hepatitis. I have given there. Anything else? Outbreak handling, yes. Why not? Hepatitis A outbreak is there. Community medicine, right? And I'll go to microbiology. How do I? The 7 steps of hand washing. I can teach in surgery. I can teach in medicine. I can teach in community medicine. Anywhere I can teach to prevent infection or safe disposal of sharps. That microbiology can teach, surgeon can teach, medicine can teach. So if you want, you can add all those elements. It depends on this particular alignment session or integration. I'll stick on to this. It is up to us to choose it, but these elements can also be taught. So I'm so happy that you saw the lacunae in this and all the aspects you have added. That becomes excellent. So you see, writing objectives is not easy. I thought I have done an excellent job. I have got 8 objectives. But it has not served the entire component of learning. So you may have to add. So that is one aspect. Now, with what and all subject you can integrate, you have told me by telling what all objectives I have to add. So if you even look into your NMC curricular volume under general medicine, this internal medicine, at the end of the internal medicine, all the competencies, they would have given each subject what all you can integrate, what are the competencies you can integrate. So from that I have chosen. In pediatrics also simultaneously, if I want to align, I have got so many competencies on viral hepatitis. I was amazed. I thought I will find only 1 or 2 in pediatrics, but there are at least 5 competencies. So when general medicine is talking about viral hepatitis, pediatrics should prepare their timetable in such a way that the next 2-3 classes they will be covering or teaching all these competencies in pediatric medicine. So where is OBG now? Can you tell me one competency in OBG? Yeah, viral hepatitis in pregnancy or liver disease in pregnancy, you can simultaneously deal with. So that's what we have done. Okay, it is all in your curriculum book. Nobody needs to write competencies. Competencies are written. It's only the objectives that we have to write and try to do the alignment. At the same time, you guys thought of integration, which is fantastic. Surgery also I can do. Come on. See here in this first competency, the anatomy is there. So when medicine need not teach anatomy, OBG need not teach anatomy, surgeons are teaching anatomy, that is good enough. The same students are listening, right? So that is a redundancy of objectives. So when I split this SU 28.1, definitely there's going to be an objective on anatomy, maybe a little bit on physiology also, right? So that is what Kishore meant by avoiding redundancy. You can share these objectives. If I have already dealt with in surgery, medicine need not waste their time talking about anatomy of the liver, right? Okay. And now the vertical integration I found in biochemistry, serum enzymes, we already talked about interpretation of the liver function test. Pathology, their etiology, pathology of viral hepatitis. Then microbiology, we have everything about the etiopathogenesis. Community medicine, etiology of waterborne diseases, jaundice, hepatitis, diarrheal diseases. Everything is there. And the extra ones that you already told, we can add. Now is a group activity, okay? I'll give you 20 minutes time each group. So first group is easy, we already discussed this. Who's group 1 now? Who's group 1, Padma? Okay, what is your color? Okay, that's why red, but everybody is red I put. Group 1, you just take a quick photograph of this. This is the competency that you're going to derive objectives and you tell me how you're going to align with what are the other competencies in other subjects in the same phase. What are the components you're going to integrate? Okay, the trick is you open your curricular volume on general medicine and you can easily get the other competencies with which you can align as well as integrate. And which method of integration you're going to use, you just mention, that is enough. Okay, so group 2 is again internal medicine, this is type 2 diabetes. Group 3 is pulmonary TB. Please take quick pictures, you have to do it now. Okay, and group 4 is okay, don't take it as parathyroidism, it's hypo or hyperthyroidism. Okay, it's about thyroid, not parathyroid. Sorry, I copied it wrong. You go and look into your curricular volume, which is a competency which is on thyroid, not parathyroid. Okay, sorry, late last night I was sleeping over this slide, I think. I copied the wrong competency. The last one is acute abdomen in pregnancy, which we already discussed a little bit during our discussion. Okay, please take this. And the surgery, please look at which competency deals with thyroid, you take one competency. Okay, what are you going to do? Can somebody tell me? What is the work I've given you? Yes? You quickly derive the objectives for this particular competency. See how you're going to align with other subjects in the same phase and how you're going to vertically integrate. If you're vertically integrating, what is a method you're going to use? If you mention that, that is enough. Linker case means no need to create a linker case. You can create that and put it in the WhatsApp group by tonight. I want every member to participate. It is a group activity. Don't give it to the person who is very enthused and the rest of you sleep, please. Okay? 20 minutes from now, somebody keep time. Thank you. Facilitators can help the groups if they have any doubts.
Which group is ready? Group red. Ready? 5 minutes. Good. What about group yellow? Ready? That is red, green. This is red. Green, red, ready? Not it. What about pink? I think we'll start. Red is ready. Yeah, please. Madam, group red is ready, madam. Others are almost. Okay.
All are ready? I'm not hearing yes from everybody. Need a couple of more minutes, we'll wait. Because otherwise, if they start presenting, you will not be listening, you will be in your own track. Each competency, I want everybody to learn something from that group. Lunch has already come, so it's up to you guys whether we can go in time or not. Group 1 is ready. Group 2, who is group 2? Group 2? Okay. Group 3. Group 3 evaru ba? Ready, group 4. No, if you want a couple of more minutes, we'll give, don't worry. Group 5, couple of minutes. Okay. Done, na? Okay. Okay, another 2 minutes and then we'll start. Otherwise, we'll be terribly late and, sessions will get pushed beyond 5 o'clock. You can listen with one ear and prepare the other one. Okay, all groups, we'll just start. Is it okay? Sorry to hurry you, but otherwise we'll be trailing behind very badly. Okay, group 1, you can present. Yes. Other groups, kindly listen as much as you can, please.
We had competency IM 2.4, discuss and describe the pathogenesis, natural history, evolution and complications of atherosclerosis and IHT.
Slideshow. Yes. So that is the competency from internal medicine.
And we have objectives 2.4.1, describe the blood supply of heart, which can be a lecture and 2.4.2.
No, you come to how you're going to teach later. Okay. You tell me the objectives first, like I showed you.
Okay.
Yeah.
One is describe the blood supply of heart. Next 2.4.2, various risk factors of atherosclerosis.
When you write an objective, how do you write an objective?
Describe the various risk factors.
Objectives, appa, the slideshow podupa. Slideshow podude. Slideshow is not coming. I don't want to see the other slide. I want you to show only this. How I have written the objective, same format. Please make it a habit. Just don't put subtopics. We don't want subtopics. You have to use a correct verb as you learnt in BCME. Is it describe? Is it discuss? Is it define? Okay, please tell me now.
Discuss the pathophysiology of atherosclerosis.
Please listen, rest of you. Yeah.
2.4.4, discuss the various clinical features of IHT. 2.4.4, enumerate and interpret the cardiac markers in IHT.
Okay.
2.4.6, describe the complications of atherosclerosis and IHT.
Okay.
We have vertical integration with anatomy A and 2.
No, first you tell me alignment first. You tell me alignment, that's how I taught you, no? Alignment means, when you are teaching in general medicine, what are the similar topics you are going to teach in pediatrics, general surgery, OB/GYN? We can take orthopedics also into it if you want.
One is from anatomy, ma'am. Sorry.
Alignment means same phase. Joshna, that means my 1 hour lecture is a waste. Same phase, I said. No, alignment is same phase across a particular timeline.
OBG and surgery.
OBG, what is the competency you're going to match with? See, that's why you guys were not ready. You wanted to be the first, but you have not got.
Disease in the pregnancies.
Sorry?
Ischemic heart disease, patient pregnancy.
Tell me the competency number from your curricular volume. That's the whole idea. Okay, which group is ready? Group 1 is apparently not completely ready. Participants, if you're willing to listen to others, we'll have this. Otherwise, we'll go for lunch. And I will think that I have taken my session very well. You're all happy. Not listening to others. Sorry. Which group is ready? Listen, I want you guys to take this competency. First tell me, derive all the objectives as Joshna has done it. Next, you have to tell me how you are going to align with other subjects using the same topic. That is the first exercise. Second exercise is with your objectives, what kind of integration you want to do. That's all I want you to tell me. She's worked on the integration, they have not worked on the alignment. I want you to work on both. Yes, group 2. Group 3. Yes, we'll go to group 3, Joshna. We'll come back to you. What is group 3? Okay, this is from the, yeah. Please listen to group 3. Yes.
CT 1.2. Is it audible?
Yeah, you carry on. Tell Srinivasa.
Describe and discuss the microbiology of tubercle bacillus, modes of transmission, pathogenesis, natural history of pulmonary and extrapulmonary tuberculosis, and pulmonary forms including lymph node, bone and CNS.
Sure.
So first, microbiology SLOs. First we'll be describe the...
Hello, I don't want microbiology SLOs. What is the subject?
Subject microbiology.
No. What is the subject? CT means
CT,
what?
chest and TB, ma'am.
You tell me objectives for this competency. Don't you divide into silos. The whole idea of integration is lost. Whole idea of alignment is lost. You come out of your subject. You look at it as you will look as a pulmonary medicine teacher or a general medicine teacher teaching this session for phase 3 part 2 students.
Describe the microscopic features of tubercle bacilli and describe the etiopathogenesis of pulmonary and extrapulmonary tuberculosis. Describe the clinical features of TB lymphadenitis and TB.
Okay.
And tuberculosis of the bone and joints.
How many objectives now?
4 objectives.
Okay. All right. You can have at least 6 more.
And
but okay, 4 you have made for now. That's fine.
Alignment we'll put, ma'am, now.
Yes, please.
So we'll go for horizontal integration, pediatrics.
Okay, what is the competence you have chosen there?
Competency number is PE 30.2.
Yeah.
34.1 to 34.8.
What is it? Read at least one competency for me.
One competency I will read it actually. Describe the various diagnostic tools for childhood tuberculosis.
Okay.
Describe the various regimens for Mycobacterium tuberculosis as per national guidelines.
Yes, very good.
Discuss the preventive strategies adopted and the objectives and outcomes of the national TB control program.
Very good. Right, any other alignment you're going to do? One with is with pediatrics.
Orthopedics we are doing.
Yes.
Orthopedics OR 4.1.
Please listen, Jyoti.
OR 4.1. Describe and discuss the clinical features, investigations and principles of management of TB affecting major joints.
Excellent.
Including cold abscess and Carey spine.
Okay, so all of you got the hang of it. So he's got a TB in pulmonary medicine, which may be taken by chest medicine faculty or internal medicine faculty. He's trying to align with pediatrics on all childhood tuberculosis and an orthopedics which talks about TB of the joint. And similar way, can you do it with OG and surgery?
Yes, we can do, ma'am.
You can do, but you have not chosen the competency.
Yes.
So you can do it over a 2-week period because tuberculosis, again, like diabetes, is a very vast subject.
Vast subject.
Any specialty you take, you will have definitely competencies in TB. Okay, so this is the alignment. What about the integration?
Integration is nesting. We are planning to do the nesting, ma'am.
So are your objectives aligned? Are your objectives talking any elements of integration? What are your objectives? Can you read it again quickly? So 4 objectives you had, no pa? You read that.
Yes. First 4 objectives. Describe the microscopic features of pulmonary tuberculosis.
Okay.
And etiopathogenesis of pulmonary tuberculosis.
Okay.
And
so this you can get from which subject you think?
Pathology, micro and patho.
Yeah. So you can. So he wants to use nesting. That means the internal medicine person or the orthopedician or the pediatrician, whoever is taking on TB, one of them will talk about the microbiology as well as the pathophysiology of tuberculosis, how it looks under the microscope, the organism, what is the whatever tuberculous lesion granuloma, how does it look under the microscope. In pathology competencies, they will integrate by using nesting.
Nesting.
Right?
Yes, ma'am.
Anything else you want to add for now? Anything else?
You can share the session.
You can?
Sharing, ma'am.
Okay, but I think nesting is an excellent idea. Sharing is a basic, nesting you're going next level. You can do both. You can share it with pathologist, ask them to take some component like an integrated seminar or something, or you can do the nesting. Both are very well accepted. So that is the way you should do it. Alignment means look at similar competencies, topic-wise competencies in other subjects. In the same phase, they have taken pediatrics, orthopedics and general medicine, that is pulmonary medicine, chest medicine. Yes. So that is good. Okay, a big round of applause for group 3. But the objectives, you can make at least 15 objectives out of this competency. You have made 4 to start with.
And in pharmacology, we are not included pharmacology medicine.
Leave your subject, I said. Leave your subject. You can get pharmacology also, definitely. But our subject silo, no, I am also thinking of surgery only first. So that is what we are born with, we are trained with, so it's difficult. But I think they have done an excellent job. Very good. Next group, who is ready? Hey, nobody is ready? You want to do? Okay. They're all the more challenging, no? You should do it. Come.
Madam, I'll sit and read.
Group 2 is presenting, that is the competency number 2.
Yes, ma'am.
IM 11.3, yeah, diabetes, obviously.
Yes. I'll sit and do, madam. I'll just read. Okay. So the competency that we have is describe and discuss the epidemiology, pathogenesis, risk factors, economic impact, and clinical evaluation of type 2 diabetes. So we have, in relation to diabetes, we have 18 competencies in internal medicine, and there are multiple competencies in biochemistry, surgery, almost all the subjects we have. So the specific learning objectives for particular competency is, firstly, describe the epidemiology of type 2 diabetes mellitus.
Okay, that is your first objective. Okay, then
Explain the pathogenesis of type 2 diabetes mellitus. Enumerate the risk factors of type 2 diabetes mellitus. Then discuss the economic impact and clinical evaluation of type 2 diabetes mellitus. Those are the 4 points that have been mentioned in that competency, and we have multiple competencies as well, which we can elaborate on.
No, what objectives you derived? Only 4 objectives again. You said such a vast topic, no?
But on that topic, we have 18 competencies, madam.
You don't worry about other competencies. For this competency, you derive objectives. Alignment is different. When you want to integrate, you have to have enough number of objectives under the competency for you to integrate effectively. Then only you will get an idea. If you don't have basic sciences objective in your competency, how are you going to integrate? You understood the way they did that?
Yes, we'll align, madam. Starting with the anatomy,
okay.
We can discuss about the anatomy of pancreas. In relation to physiology, the endocrine functions of pancreas can be dealt with.
Okay.
And in relation to biochemistry, interpretation of the FBS, PPBS, HbA1c can be done. In relation to pharmacology, anti-diabetic drugs and their evolution can be derived.
Yes.
In pathology, pathophysiology of diabetes and gross and microscopic pathology
okay.
of
We'll stop this thing for integration. How are you going to integrate this? No, alignment is different from integration. Alignment you're going to do with so many competencies and other subjects in the same phase. He's read out all these subjects have got competencies in diabetes. This 4 objectives you have given, no? How are you going to integrate it? Which technique you're using for integration?
Nesting can be done.
Yeah, what will you do? Can be done is so many things can be done in life. What are you going to do for your students?
Linker case.
Linker case. I think diabetes is something that you can use this linker case across, starting from anatomy when I describe the parts of the foot. What is the blood supply of the foot? Because that is a diabetic foot infection is the most common. As a surgeon, I can see that. You can talk about the pancreas, the endocrine, exocrine function of the pancreas, starting with anatomy. You can go up to geriatric medicine, talking about diabetes. So one well-developed linker case is going to help you integrate components across. So if you're using a linker case, what is the principle of integration used? What is it called? Correlation. Exactly. So you're correlating so many basic science aspects using a linker case when you're teaching in final phase, it is phase 3 part 2. Okay. So they said they will align with all other subjects in that same phase. There are n number of competencies and 4 objectives you have to, so every time you write an objective, again if you go back to my slide, again I said the 8 objectives I have written, you found so many other objectives that could be added, right? Audience only gave me feedback. I could easily add another 6 objectives to it. So remember that the way you derive the objectives only will help you align and integrate. Alignment may be easy, but if you want to integrate, you have to start from the basics even when you are teaching in final year. You are bringing back components from first phase into final year class. So that, hey, you learned anatomy and physiology only for this reason to understand diabetes better, right? So you have to have in your objectives that those that refer to basic science. Then you can integrate using nesting, or you want to do with a linker case, that is correlation, that is also excellent. Okay, a big round of applause. I think it's a very vast topic. They have very succinctly put it how they want to do it. Which is the next group who's going to tell us. Now your job is easy. 2 people have nicely explained. Everybody will say, like that group I will do it. No, I want you to tell me exactly your objectives. Yes. Which is your competency, Sai?
Group 5, madam. Group 5.
Okay, OG. Very good.
9.3. So we derived the following objectives. The first objective is describe the pelvic anatomy. The second one is list out the risk factors of ectopic pregnancy. The third one, explain the pathophysiology of ectopic pregnancy. Describe the various clinical presentations of ectopic pregnancy. Mention the possible differential diagnosis in a pregnant patient with acute abdomen. Interpret the laboratory parameters, radiological features in a pregnant with acute abdomen. Discuss the management protocols of ectopic pregnancy with complications. Counseling the family attenders in a ectopic pregnant patient with presented with shock.
Okay, very good, excellent. So you see, you are building more complexity into it by getting communication skills, counseling skills. Very good. Interpretation, which they already said, lab reports they will interpret. Okay. So now how are you going to align?
Alignment. When we saw the NMC protocol, there is no alignment with other thing, but we derived the one alignment with general surgery.
Don't go by NMC protocol. NMC is giving the minimum necessary things to give an idea to us. You can go the next level. Okay.
We can align with the general surgery topic. Describe the clinical features, investigations, and principles of management of acute abdomen.
Okay. Which competency number is that? SU? Something will be there. Okay.
SU 28 and 2818.
Okay. Anything else you can align with?
You can align with general medicine.
Maybe Shalini, she is subject expert. She is telling you can align with general medicine. DKA can mimic an acute abdomen. So whenever acute abdomen pregnancy comes, one of the first thing is ectopic pregnancy. The second thing is you should rule out a DKA if the sugars are high, that is. So that can mimic an acute abdomen. So she says you can even bring in that competency if you wish. In general medicine they will be discussing, or in OG only they will be doing DKA in pregnancy. Okay. So basically you think you can integrate, you can align essentially with general surgery for this topic. Okay, fair enough. Then integration.
Nesting is a method we use for explaining this topic.
So which components you are going to nest?
Nesting.
Which are the elements you are going to nest? Which objective requires nesting?
Nesting. First, describe the pelvic anatomy.
Yeah. So pelvic anatomy or the anatomy of the abdomen.
Physiology.
What physiology objective you made? You have not made any physiology objective.
The various risk factors.
Okay, but you have made something in interpretation of the lab reports and some X-rays you said. X-rays we don't take, ultrasounds.
Radiological features.
Yeah, so that is, again it goes back to what is the normal anatomy of the uterus or the abdomen, what are the abnormal fluid collections, all those things. So you have some element of integration you want to do using only nesting. Why not a linker case?
Yes, linker case also can. Both of these, both are good.
Yeah, I think, but nesting is easier. Linker means you should link from phase 1 across to phase 3 part 2. It may be overdoing it. Nesting with what is that? OBG faculty taking that in their own lecture is good enough. Okay, thank you. Very good. Who's the next? Applause. Quickly, next group. We are already half an hour exceeding time. Which is yours?
Group 4, madam.
I said parathyroid, sorry, thyroid you have to do. Okay. Quickly.
My SLOs are describe the anatomy of thyroid gland, describe the physiology of thyroid gland, describe the etiopathogens of thyroid swelling, correct way to clinically examine the thyroid swelling, demonstrate the clinical features of thyroid swelling, discuss about the differential diagnosis of thyroid swelling, demonstrate how to interpret TFT in hypo and hyperthyroidism, management of hypo and hyperthyroidism, how do you counsel the patient for surgery. It come.
Okay, excellent. Now how you are going to align, how you are going to integrate?
Alignment I'll do with anatomy, physiology.
Hello, is that called alignment?
Sorry,
I'll tell you I'm saying in Tamil, but I won't tell because you may not understand.
In medicine with mixed edema, OBG thyroid in pregnancy, pediatrics congenital hypothyroidism.
Do you have already competencies in NMC volume for all this?
Yes, madam.
It's already there. Okay, so pediatrics you will align. Why not our poor general medicine people, yeah? What is this?
Madam, mixed edema.
You internal medicine only, in fact they will talk more about, pituitary failure, this failure, hypothalamus. They are the ones talking to us about the negative feedback, axis.
Yes, madam.
So medicine also definitely you can align. Yes, thyroid means medicine first. That's what I will think.
Alignment with medicine, mixed edema, OBG thyroid in pregnancy, and pediatrics congenital hypothyroidism. Integration with linker case or correlation and nesting, madam.
Both. Okay. So you see, you guys have stopped sharing. You're going to the next level, up the ladder of Harden. That's good, because sharing one step higher will be nesting, one step better will be using a linker case. But we can't create so many thousand linker cases for every topic. So you depend on everybody, all the faces have to sit together and decide this is a linker case and this is how we are going to use it through the curriculum. Okay, good, great. Big round of applause. We'll come back to Joshna. Joshna, yes, you all. Joshna always has the last word. In the department, I know it's true. Yeah, please.
Ma'am, alignment with OBG and surgery, ma'am. Our topic.
Which is your topic? I forgot.
From this. I am 2.4, ma'am. First topic.
Okay, no worries.
I am 2.4.
IHT. So how are you going to align with OBG and
surgery, ma'am?
How? Which competency comes?
Surgery SU 26.1, ma'am. Role of surgery in the management of coronary heart disease or valvular heart disease.
Excellent. Yeah, that's what I wanted. You think surgeons have got nothing to do with MI, you are all mistaken. Okay, we are there to operate on the patients. Okay, good.
And one more topic, SU 27.1, to describe etiopathogenesis, clinical features, investigations and treatment of occlusive arterial disease.
Okay, why is it important to align that?
Atherosclerosis.
Basically, yes. So anybody who's got a coronary artery disease definitely is going to have some peripheral arterial occlusive disease also. So it makes sense to align that at the same time. Yes.
And OG 12.4, ma'am. Define, classify and describe the etiology, pathophysiology, diagnosis, investigations and adverse effects on the mother and fetus and management during pregnancy and labor, complications of heart disease in pregnancy.
Okay, maybe exactly not ischemic heart disease, that is maybe most likely valvular heart disease or something else, or a toxic myocarditis, but still it is okay. At least cardiovascular system you will be discussing at the same time. So that is good enough. Excellent.
Integration with anatomy AN 22.3, ma'am. Blood supply of heart.
Yes.
And
so first you should make your objective on that, to understand the basic anatomy of the coronary circulation. If you have an objective, then you will be able to integrate. Anything else you want to integrate?
Pathology, ma'am. PA 27.5, describe pathology of atherosclerosis.
Excellent. So how are you going to use this integration? Which technique you are going to use?
Vertical integration.
Yes.
And
what is a method?
Nesting.
Okay, so all of us have become birds now. Ellaru nesting. Yeah, I think no, nesting is good enough. It's a very good way of doing it. Linker case again can be used if your AITO topic is going to be IHT. It's going to start from anatomy, go right till the internship. Then the linker case, that correlation is also an excellent way. Okay, I think we all earned the lunch now. Thank you for your patient hearing. I hope you retain these concepts when you go back to the department day after tomorrow morning and try to help your HOD create the AITO timetable or aligned and integration. Thank you very much. Thanks. I should thank Dr. Kishore also. Come back at 2:45. 2:45. Half an hour lunch break. Okay, before you go to lunch, one repertoire is Dr. Vijeta for tomorrow morning. She's going to tell about today. What about tomorrow's repertoire? Who is the volunteer? Otherwise, I will name somebody. Who wants to do the repertoire for tomorrow session? At the valedictory, you are supposed to do it quickly. Shall I nominate Dr. Ashish? Ashish, you will do it? Okay, Ashish, thank you so much.
but still we were listening.
First, what did they do?
Inauguration, this thing, introduction. It is there, no? It's the same. దీనికే ఒక రెండు యాక్ట్ చేసే అంతే. ఇది చెప్పు అంతే. వాళ్ళు హ్యాపీ అయిపోతారు. It was dealt very nice by appreciation చేసి. Ma'am, what is the time, ma'am? Exit time today? Madam, exit time. 6 is difficult, ma'am. They're waiting in my house. My relatives, they want to go out. If not, they will bash. Already they're bashing me.
So good afternoon everyone, welcome back to the post-lunch session. We'll continue our sessions. Dr. T.P. Sudhakar sir will be taking the AdCom session for you now.
Good afternoon. Usually the post-lunch sessions, you know, postprandial sleep will be there. And as such, this subject itself is quite abstract. More to do with the affective component. So I will try to keep you awake. Most of you must have heard about this particular thing. In the competency-based medical education, we are going to impart some competencies for our medical graduates in their attitudes, ethics, and of course, we have to improve their communication skills. And you have got various modules starting from the first professional year to fourth professional year for all the medical graduates. And if you have this book with you, you got it? Anyway, we can go to some of the modules here. If I actually take an extensive class on this, probably it may take, or even it requires about 1.5 hours to 2 hours. But I will try to make it sharp and short. How many people amongst you will accept my concept here? Raise your hands. I'm not seeing any hand being raised. Somebody disagrees with me? Because always I find, I'm in government practice as well as private practice right from 1979. It is almost 45 years plus. And throughout this particular phase, as time passes on, I found that practicing medicine actually is an art. We know a very little science in medicine except for some super specialities. In most of the routine practice we know very little. That too in psychiatry we still know very little. But how you put it across to the patient and make it more palatable, that's important. So that's where I find that practicing medicine should be an art rather than a science. And this concept should go to our undergraduates. So in this AdCom, we will first talk about the attitude. Anyway, I have given you what exactly attitude means. Attitude is a very common word which we use day in and day out. We keep saying that his attitude is good, his attitude is nice. So attitude is a sort of a fixed reaction which you show to various circumstances. It refers to a set of beliefs, emotions and behavior to particular people, to particular situations or to particular objects. And as you know, your attitude starts developing in the childhood. It keeps developing based on your day-to-day experiences as you grow, and after some time it gets more or less fixed. So in the early stages your attitudes can be changed because they are still flexible. You can try to change it, especially among the younger graduates. Always there is a chance that we can change their attitude. But as you grow old, once you reach 60 or 60 plus like me, then probably you become more rigid. It's difficult for you to change. And I'll be talking a little bit of ethics. All of you know about ethics. Ethics contains lot many things here. We will be restricting ourselves to medical ethics, the way in which we are supposed to practice medicine. And here, far as the important things are patients, what sort of ethics we have to follow with the patients, and with our peers, our colleagues, our superiors. And of course, especially among us, lot of clinicians must be there, and we will be dealing with various medical industry people. And NMC already had given lot of guidelines like how to entertain these people, what are all the things, what restrictions are there. Anyway, we will not be going into the detail, but we will be only touching upon some of these things. Everyone knows about these things. I am not going to dwell much upon this. Important thing is beneficence. Do good to the patient. Non-malfeasance. Do not harm the patient. Autonomy. Respect patient's independence. The patient's right to refuse or choose. And of course, you regularly know about the importance of informed consent nowadays. Then justice. You have to treat everybody equally, and everybody has got a right to get equally treated by the doctor. Then you should realize the patient's dignity and privacy also. Both these things are very important. Patients have got their own rights. If they say that don't reveal it to the other person about my problem, you have to respect it. Unless patient gives it in writing that you can really leak this information to this particular person, you get that documented, then only you leak that information to the other person. Only exception for this could be some of the legally related matters where the magistrates or the judges ask for the information, there you need not maintain the confidentiality, or some of the things where it is important in the best interest of the society or the best interest of the country that you have to open up and reveal things to various authorities. Truthfulness and honesty, probably this is one thing which we lack nowadays, especially with the present generation as well as the present patient populations. Still we can develop this and improve this profession into a noble profession again. And lastly, I will be talking about communications. Communication really matters when you are seeing a patient, and communication also impacts not only the diagnosis when you make in a patient, then how you impress upon and communicate with the patient, it will actually will influence the adherence of the patient. Then the patient satisfaction, nowadays we call it as customer satisfaction or client satisfaction. Nowadays we don't even call patients as patients, we call them as clients. And of course your own satisfaction when you are treating the patient. And this good communication can always avoid malpractice litigations. If patient is well informed about the things, most of the times there is a very meager chance of he approaching a court or a lawyer. Again, how many of you can really answer this? Is communication only verbal? Or you think that there are other ways of communicating? Verbal is what I am doing with you now. But at the same time, I am making many gestures. That's again a non-verbal communication. In addition to that, I also make some faces, or there will be some sort of an emotional display on my face, which probably most of you can understand. Whether I am irritated with you, or I am happy with you, or I am enjoying this lecture at this juncture or not, all these things you can make out. So actually communication need not be necessarily a verbal communication. Actually 55% of the communication which we make with our patients is non-verbal. And there are many doctors who don't even look at the face of the patient. That's a very bad practice. But there are many people who do that, and probably we should not develop such Indian medical graduates when they undergo training under us. So which domain has to be strengthened here? You must have read about this, Krathwohl's affective domain. Here important is receiving, and once you receive the information, how you respond to that, how you value that, how you organize that material, and how you integrate it into values of everyday lifestyle. So it is an ongoing learning process for every one of us. Here there are 5 steps, as I said. The most important thing is valuing and internalizing the patient's requirements and what they expect out of us. That is very, very important. I will just very briefly talk about some of the things. Why we are talking about AIDCOM today is the fact that we have got various roles for the Indian medical graduate. He has to work as a clinician. He is a leader in the health group. He is a member of the healthcare team in general. He is a lifelong learner. He should be a good communicator, and at the same time he is a professional who has got the knowledge about treatment. The goal of our systems approach is to produce an Indian medical graduate who is highly professional. You know what do you mean by profession? we practice medicine, and when you are practicing medicine, people have got expectations when they come to you, and you should be in a position to live up to that expectations. And initially I used to see in this campus itself people coming in jeans and t-shirts sitting in the OP. There were many instances when I threw them out because this is not professionalism. Actually this is where people hate us and they curse us. So I think this is one of the most important component when you actually train your students or internees or even postgraduates in the profession. So it has got lot of regulations. You should have the inner regulation to control yourself, and you should actually act as very dignified manner, and you should show that you are more specialized knowledge on the subject, and you are following the ethics very strictly, and at least you should give the impression to the patient that you are really concerned about their welfare. So here nurturing, love, caring, empathy. How many of you know the meanings of each and every word here? I think it's not difficult, you can know it. As a professional, as I said, you have to be compassionate, you have to be caring, you have to have ethics, you have to be very responsive to the patient's needs, and you should be committed to excellence. You should be accountable to the patients, to the profession, and to the community. And you should try to derive respect from others. So this is why we are talking about EdCom today as a part of the curriculum in competency-based medical education is. This is a very important component probably we have been doing since long time, but we never recognized it that we are practicing all these things. Those days it was not in a proper format, it was not considered as a competency to be taught, it was more of a competency you develop over a period of time. But nowadays we consider the importance of this EdCom model, and we start incorporating some knowledge to the IMGs about the importance of it, and formally what we say and hidden what we do. Both the things, as a teacher, as a doctor, as a senior, when you do it in front of your juniors, they learn it without their being aware of it. Anyway, I am not going into the details of this formal curriculum. Altruism, of course, you can forget about it. Not many people cannot really aim for it. But the other two things, empathy. You should understand the other human being. You should look with his eyes. You should listen with his ears. You should feel the pain in the heart of his. This is empathy, compassion, kindness. These are the things which actually if you demonstrate to the IMG, they can definitely pick it up from you. And when it comes to failure of communication, you know the result of that. The cartoon shows how hospitals are attacked, how doctors are attacked, how we have been doing so many strikes all along against the governments. This is because we actually project ourselves. I'm not trying to criticize our profession. What I'm saying is, if you actually perfectly follow whatever is expected out of you, you can reduce these incidences tremendously. Anyway, don't bother about this Collins criticism about us. He says, today's culture of medicine is hostile to altruism, compassion, integrity, fidelity, everything. He says these present generation doctors are the worst possible human beings. They are probably worse than politicians. Actually, he himself is a senator in US. Anyway, we are not concerned about him. Indirectly, I want to say that even in US, things are deteriorating. But always there is a scope for us to uplift it. That's what I'm talking about. We can incorporate these professional values during the learning process. And whenever people learn it during the training period, probably it will last for a long time. So that is the advantage. As I said, you can keep learning it even after becoming a doctor or even after becoming a specialist. But if you start learning it right from your early age, probably you will mature faster and it will be more incorporated into your routine personality itself. So this EdCom module which is there given in this book, it will have basically a competency based model, structured longitudinal modular program on attitudes, ethics and communication, explicit way of teaching attitudes, ethics and communication. Professionalism is the core competency here, and we have to teach and assess the professionalism during their training period right from the first professional year. And we have to assess both subjectively and objectively how much they are learning on this professionalism. Actually, you have got total 54 competencies here given, spread over a period of 4 years under 27 modules. If you have this book, actually you can go through this. If you don't have it, probably it must be available on your cell phones or laptops. And 140 instructional hours will be there exclusively for learning this, and it includes self-directed learning also. So you have allotted some time for the students to learn on their own. And usually most of the things can be better taught in small group teaching. You cannot really separate out this particular aspect from your routine clinical teaching, but you can always incorporate it whenever you are demonstrating a case. You can pick up certain of ethical issues or certain professional issues when you are seeing the patient and ask the students what they feel about it. So it can be incorporated into their learning itself so that it will last longer in their memory and it is easy to learn also. There is no hard and fast rule here that only you should teach in this particular pattern. You can be very flexible with it based on your convenience, based on the facilities available, based on institutional support, based on the nature of the patients. You can always modulate and modify these particular competencies. Out of these 54 competencies, at least there are 39 core competencies. That means they are must, not only desirable, they are must. They should know, our children should know. Hybrid problem-oriented approach. As I said, you adopt your own, in your own way, how can you really teach these things. Give importance to self-directed learning. 2 or 3 students together can sit, they can ask questions, they can answer the questions, they can probably learn it in a better way doing that. Sometimes you can use real life case scenarios, as I said, or simulated case scenarios. OPDs, wards, field visits, all these things can help you in really making these people to be very professional. And of course, most of you must have seen the logbooks which these people maintain exclusively for EdCom model right from the first professional year. Most of you must have seen that. This is one of the logbook for the first year students. I usually, when it comes to EdCom model, I usually hate a didactic lecture of this sort. I don't think especially young children can really understand when you talk about it. maybe DOAP, small group discussions, paper cases, simulated patients are role models among the students themselves, probably can give a lot of insights to the students. Mentoring, as I said, silently it makes the student learn how to deal with a difficult situation. So probably you can try some of these things. And when it comes to assessment, there is a process evaluation based on process of teaching, learning by case scenario approach. And you can always do a progress evaluation throughout the course and product evaluation at the end of the internship with all the students. These are some of the other methods. Here also I like probably 360-degree evaluation to anything else in the list, because always it gives you an idea like how everybody feels about a particular student, what he had learnt when it comes to learning about this attitude, ethics and communication skills. So there are 4 sections in the EdCom model. And as I said, these 4 sections basically relate to 4 professional years. And you have got 2 appendixes. You can actually, once you go back home, you can look at the EdCom model book. And again, as I said, you should know whom you are teaching and what you are teaching, when you are teaching and how you are teaching. These 4 components are very important. And at the very opportunity, we start dealing with this particular teaching methodology, so that whenever you get an opportunity to really talk about EdCom, you can always do that. As I said, in section 2, you have got learning modules for professional year 1, 2, 3, 4. And this is how it goes on. You have got in the first year 5 modules, 34 hours. And in second professional year, you have got 8 modules, roughly about 37 hours you have to exclusively devote. Third professional year, 5 modules are there. Probably this is the shortest apart from the first year model, 25 hours. And 9th is the largest, because by that time our students have already been exposed to clinics, they have been visiting various specialty subjects, and probably there they have to spend much time on EdCom. Logbook writing must be made compulsory, because we should know how much competency has been acquired by our students. This self-explanatory formative elements to be marked by the tutor. What is the desirable competency and to what extent it has been achieved. It could be a simple formative assessment. And in the appendix, you have got, as I said, 1 to 39 are core competencies which one should know definitively, and there are about 13 other things which are desirable, but you need not really go about it. How many of you heard about Kalamuju's consensus statement? Must have. So this is the module 1. This is basically meant for the first clinical year. What really it means to be a doctor. The person who enters the medical college should know what exactly it is to become a doctor in future. Then once they pay a hospital visit, you have got an early exposure to the hospital under the first clinical year. So there probably the doctor-patient relationship and how patient feels sitting in the hospital and the foundation for communication should be properly made to be learned by the student. And one should understand the cadaver is their first teacher, and one should know how to respect the cadaver itself. So this is the time allotted for each module, and the last column talks about the assessment, whether it is required or not, if it is required, whether it is formative or summative. In the first year, nobody is very serious, but it is better if you can assess it if you have the time. Definitely it will give you an idea where you stand. In module 2, I've got foundations of the communication. Here we concentrate more on ethics as well as the communication, because by that time the student has entered the clinical year. Healthcare as a right is very important. Our students should understand healthcare is everybody's right. And how people work in a system, healthcare system. Our students should understand that. Then the bioethics control study, case control studies on patient's autonomy and decision making. In olden days, you know that usually patient will come to you and they say that, sir, you take a decision. Whatever is the best for us, you decide. You do whatever is best for us. Nowadays, the concepts have changed. In the modern day, we should respect the autonomy of the patient. And if patient says, I am not interested on this, best is to give the choice to him. You can give total information related to the disease or the treatment. Sorry. But the decision is patient's. And you should understand what is exactly the position of a caretaker in the family. So that's very important. Actually, that's where our people get beaten up, because we nearly never bother about who had accompanied the patient, what is their distress, how much difficulty they are facing in the hospital, how much information had been imparted to them. These things we never bother. They are kept in dark about these things, and this leads to lot of miscommunication, and they presume that the patient is not being taken care properly. So as I said, this module 2, you have to really concentrate more when you are training the Indian medical graduate, and make sure that in future our doctors are more dignified, more responsible. They never get beaten up or accused of malpractices. Then this foundation of communication in this module also continues. Here we will probably concentrate more on medical errors. You know, we do not many medical errors or medical negligence. Actually, you may not be knowing the percentages are very high. If you take right from the mild errors to very serious errors, we do lot many things without we being aware of it. Probably you have to go through it and make our students understand that in this practice of medicine, you always have a chance to err. Error is, after all, is human. But how to minimize it or cover it up, or inform the patient properly about wherever things have gone wrong. Again, that gives you a lot of respect for you. And the other important thing here is confidentiality. As I said earlier, if patient's confidentiality has to be maintained. Unless patient gives you a permission, don't give her information or his information to anybody else, even own spouse also. That's better. Fiduciary duty, you know that. So once you become a doctor, once you are there available, it is your duty to attend any case first. At least make sure that you do some first aid. You can't refuse. So that is your fiduciary duty. In module 4, of course, in 9 modules, again we talk more about the various foundations. We are, again, by this time, probably most of our students might have completed forensic medicine also. So we can deal more with medical legal cases and various probability of various ethical issues, which could be quite confusing for the new medical graduate. Then case studies in the medical legal cases can be discussed. Case studies in ethics, empathy, especially when it comes to doctor-patient relationship, can be highlighted. Case studies in ethics, empathy, and doctor-industry relationships is also important, because by that time most of our students, once they reach the internship level, most of this medical company will start approaching them, give them a free lunch, give them some gifts, give them some free samples. Nowadays, of course, these things have gone down, but still it is there. How to deal with such situations, you have to teach them. And among the next last, is 4.6, 4.7, 4.8, and 4.9, I think medical negligence I'm not going to deal in detail, but I will talk about how to deal with death. I think most of our students require handling these situations. How to break a bad news, how to say and when to say, where to say, whom to say about a patient becoming bad, and he probably likely to die. How to handle their emotions, how to console them, how to make them understand that things are getting out of hand and this is what we can do. And these are all the other alternatives available. If you want, you can utilize it, but despite all that, probably we may not be in a position to really save the patient's life. So these detailed discussions may be necessary. Probably this is my last slide. I will open up the remaining time for discussion so that probably we can make it more interesting. So conclusions in the EdCom model of whatever I have discussed so far is, you have to make our people learn professionalism. And this learning is a continuous learning, and we keep learning it in increments, small increments as time passes. Involve students in community-based social service activities, and our people should understand that always we are indebted to the society and we should serve them. So this is again important. Develop a robust mechanism of faculty development. That's what we are doing with you people. Teachers' influence as a role model, you should understand it. So at least in front of the students, you should behave in a very dignified manner. Then strong institutional support is needed for really carrying out all this. Thank you very much. I think I will open it up. Actually, I will rather encourage some sort of a discussion amongst you, and each group can have some sort of a discussion. And if you have certain issues to be discussed, I will come back maybe after 10 minutes. We can discuss about these things. You can take a pen and paper, write down certain things which may be of importance related to your specialty and in that particular group. Okay? Thank you.
Here, part 2 examinations. And assessment, it can be formative and based on the logbook and portfolio submission. And yes, you can also allow the out-of-institute electives in both the blocks. So these are the examples of block 1 electives. So physiology, pulmonary function test, cardiovascular parameters, neurophysiology, histology lab, microbiology, karyotyping, hematology lab, and central skills lab, bioinformatics, community assisted living, community-based hospice care, school health programs, maternal child health. These are some of the examples of block 1 electives. And so block 2 electives, most of our clinical departments, including the super specialty departments, can offer electives in block 2. So these are the Block 1 experiences we offered at AIMSR Chittoor. So we had 34 Block 1 electives, which we have offered for almost 146 students. So these are all the electives from the Block 1, from all the departments: anatomy, physiology, biochem, pharmacology, micro, patho, forensic medicine, community medicine, and others. We also have an elective in humanities, and we also have an elective on computer and AI in healthcare leadership development. And these are the examples of Block 2 electives which we have given in our institute. So we had electives from general medicine, general surgery, anesthesia, pediatrics, DVL, psychiatry, ophthalmology, ENT, radiology, and respiratory medicine. So this is how the process we have followed in our institute for the electives. So the HODs were called for a meeting, and the concept of electives were explained for the HODs in detail. And we have circulated the NMC document of electives to all the HODs and the faculty. And HODs were requested to sensitize the faculty of respective departments. And the template for Block 1 and Block 2 electives was circulated. So once the HODs discussed, they identified the preceptors who were interested in taking an elective. So the templates were circulated to all the preceptors. And then the preceptors were asked to fill in the templates and send it back to us. So the received filled-in templates were scrutinized by a team of experts. Parallelly, the students were sensitized regarding the electives, the objectives, duration, and the allocation process. So, and once the final lists have been prepared, the list have been circulated to all the students. So the list contained all the templates which have their objectives, prior learning material needed to participate in the elective. Everything is circulated to the students. And we have announced a date of choice filling, and the students should be ready with their top 3 choices. And we have prepared an Excel sheet with the list of topics and the number of slots displayed for Block 1 and Block 2 separately. And students were called in order of computer generated random numbers to eliminate any bias. So we have generated a computer based random number, and students were called on that number. So when that number comes, they will see what are the available electives. They will choose their Block 1 and Block 2 electives. Suppose if the first option is filled, they will come with their 3 choices, 1, 2, 3. So they will see if the second option is vacant. If that is also filled, they will see what is vacant and they will choose that option. So this is what we have followed in allocating electives. And so now I would like everyone to plan an elective from each group. So few groups can do Block 1 elective and other groups can do Block 2 electives. So which is not a part of your already given elective. So please don't write your electives. So please discuss and come with one elective. So I would like to take the help of Dr. Siddharth sir in this group activity. So will you do Block 1 or Block 2 elective, ma'am? Block 1, okay. So which block elective? Block 2? Will you prepare Block 2 elective? It should not be a already existing elective. Block 2? Block 2. Which block of elective will you prepare? Block 1 or Block 2? Block 1 pharma, but that should not be a already existing elective. Block 2. Okay, done. So you have 15 minutes of time or 10 minutes. So So this is the template. So I would like all of you to prepare your elective with this in this template. Yeah. So elective should not be a part of their regular curriculum. It should be something out of their curriculum. And it should be interesting. Students should feel the interest to take your elective. So once you decide, please write it on your flip charts. 2 minutes you can write on your flip charts, please. Yeah, quickly you can write on flip charts.
షెడ్యూల్లో 5 దాకే ఉంది. 5 తర్వాత ఎక్స్ట్రా అయితే ఎక్స్ట్రా పే కావాలి.
అందరు రాస్తాను, మీరే రాయండి. Yeah, please finish off in a couple of minutes. I think Group A is already ready with their elective. Great. We'll wait for a couple of minutes for the others to finish their writing. So yeah, because group 1 were ready very on time. So can you please read out your electives?
Yes. Electives from the Department of Respiratory Medicine. So name of the block, it's block 2. Name of the elective is polysomnogram test. Location is respiratory medicine sleep lab. So name of the preceptor is myself. Learning objectives is to understand the indications for polysomnogram, to understand the procedure for performing polysomnogram, and to be able to diagnose, to read the results and diagnose the different sleep disorders. So number of students we can accommodate is 5. So prerequisites is knowledge of sleep cycle and various sleep disorders. Learning resources is Fishman textbook of pulmonary medicine. List of activities is mainly history taking and performing the polysomnogram test. Portfolio requirement is case of 10 reports of at least of 10 patients. Logbook entry is required and details of all cases and reports attached. Assessment is mainly by reading the polysomnogram test reports and attendance and completion of their logbooks. That's it. Thank you.
Thank you, sir. That's an interesting elective. Anyone wants to add something to the objectives sir mentioned?
Any other way of how you can assess the student? Mere completion of logbook, how credible is it?
Mainly different. No, mainly by the test reports, assessing the test reports of polysomnogram reports. It's mainly the formative tests like that we can do it.
After performing the test, can you also make an activity that to write the diagnosis or to come?
Yes, yes, definitely.
That also can be added.
Yes.
Otherwise, good. A big round of applause. Thank you so much, sir. So next we'll move to group 3.
Name of the electives and name of the block 1 from pharmacology department. Name of the electives is prescription audit, location government hospital, and internal preceptor Dr. Srinivas. Learning objectives: how to write a prescription accurately, how to analyze the areas of prescription, and how you evaluate errors in prescription writing. And number of students is 10. Prerequisites is to collect treatment copies from various departments. And learning resources are from the pharmacology records and other standard books of pharmacology, medicine. And list of activities is by doing small group discussions, 2 to 3 groups, by keeping debates and quiz. Portfolios is assessment of correct prescriptions. For each student will have 10 prescriptions. They have to identify the mistakes and they have to and the logbook is by entering 10 correct prescriptions from various departments. And assessment is by formative assessment.
Just you can count how many prescriptions are correct or not, whether they are printed correctly or not, and then we can assess as a preceptor.
So any other prerequisites?
Records we can keep actually, pharmacology records, because they'll be knowing, we'll be dealing for them how to write a prescription.
You want to go and where do you want to collect your treatment copies?
Treatment copies, OPD, IPD, as well as MRD.
Okay.
It could be like prospective, retrospective.
You have 10 students and you need 100 prescriptions in total.
Yes, 10 for each, 10 each.
How do you assess?
Assess, we can do formative assessment, sir. Like after doing the debate and all, we can keep the count how many are doing the correct, like out of 10 prescriptions from each student, how many they have correctly done, that we can compute and then we can take the percentage of it.
What is the role of quiz in your activities?
That will keep interest, like that's an activity, 1 or 2 activities can be given, like 3 groups we can divide. One prescriptions we can show them. So they'll be trained again. They can do that one on their own.
You can prepare a checklist.
That also we can do. Checklist can be prepared. Whether they have written all dosage forms, schedule, like drug names, rationality. Evaluate prescriptions. Yes. Yes. That we can add. Organized and structural, and it will be easy for them, hassle-free it is.
And for you also to assess it.
It will be easy.
And who will be cross-checking whether they have done it?
Perceptor will be cross-checking.
Done. Thank you. A round of applause for group 3. Next. Group 4.
Group 4, Block 2, Phase 2, Part 2. Name of the elective, Podiatrics, Department General Surgery. Location of hospital, DHH Chittoor. Name of the preceptor, Dr. Uday. Learning objectives, to know the biomechanics of foot, able to know the principles of management of ulcer, able to do dressing of an ulcer correctly, able to do counseling regarding the foot care to the patients. Number of students, 10. Prerequisite for elective, from the given material, learning resource, Bailey and Lowe, videos, simulation lab, and basic human anatomy book. List of activities where students participate, dressing of the patient in operation theatre. Logbook entry, number of dressing scene assisted directly or in the simulation lab, number of patients counseled regarding the foot care, number of cases assisted or seen in operation theatre, assessment by MCQs, skill testing on manicure or the patient, and by 8com role play, how he is counseling the patient.
The topic looks interesting. I think you will comment it better, but I am not convinced with the assessment part.
MCQs, how do you assess?
No, when you have the real patients and the students are observing the real.
So you cannot give MCQs. No?
After the whole electives.
So at the end of the electives for.
During the portion skill testing and role play.
So you want to have a small test after the electives is done.
No, when you are actually sending your students to the patients and making them observe the real world patients and all, why do you want again to go to a skill lab and do it on a mannequin?
First we'll show them on a manicure, then we'll take them to the patient.
Okay, I think that is fair enough. You're trying to teach on the mannequin, then observe, then you're testing on the mannequin again how they will do the dressing or foot care. Why MCQs, but? Are you taking theory class here in your electives? No, if you're having some theory component which you are giving as an introductory class, on that you can take MCQs. So you have to plan it accordingly. Otherwise, I think it's a very nice thing. It's a subspecialty evolved out of general surgery, orthopedics, and diabetology, endocrinology. So I think it is something different that the students will experience. It's a holistic care of the foot, basically, right? Yeah, thank you.
Thank you for an elective idea for next year. Yes. Moving on to the group 5.
So this elective is from Department of General Surgery. It's block 2. So it's the name of the elective is Polytrauma Care, and the location of the elective is Casualty Department, AIMSR Chittoor. So the internal guide is Dr. Sai Teja, me, and the external guide is Dr. Dhananjaylu, Professor of Anesthesia. So the learning objectives are to identify different types of injuries and to manage stable and unstable patients by triage, and to perform BLS in emergency settings and unstable patients, performing basic first aid and seeing minor OT procedures and timely referral to concerned specialties. The students accommodated, we can around 10 people. So the prerequisites, resources from textbook of surgery, orthopedics and emergency medicine. So the list of activities they can do or observe is suturing, the first aid, dressings, securing IV cannulas, IV fluids, and blood transfusions in case of emergency, achieving hemostasis, performing BLS protocols. So the portfolio will be attending prior skill labs and BLS sessions. So logbook, you can maintain the logbooks. So we'll assess them by format assessments, by ASCII or case-based MCQs.
How can simulation work in these cases?
The case, we can give the case-based scenarios for them, like real case scenarios, and we can assess them by what we can do. The first aid, we can ask them to triage. What is the emergency care is needed for them? Like mannequins. Simulations also.
Before making them perform blocks, are you planning to do a one-day BLS training session for the students?
It's better because they'll come to casualty. They won't have idea much about what type of patients.
Just finish phase 3 part, they won't be knowing
exactly. They can have some BLS I mean mannequins, any skill labs. Yeah, yeah, sure.
Thank you so much. So group 2.
Good afternoon. My elective is non-test training. Name of the block, it's block 2 elective. And location is labor room of district government hospital. And name of the preceptor, it's me, Dr. Shalini. And the specific learning objectives are, the student should be able to identify different components of NST machine, should be able to connect the probes correctly on the patient, should be able to take the graph properly, should be able to interpret the NST graph and correlate clinically with the patient condition, and should compile a data of at least 50 patients. Number of students are 5. Prerequisites: students should read basic standard textbook Williams of obstetrics and ACOG guidelines on CTG and NICE guidelines. Learning resources: American College of Obstetrics and Gynecology website, NICE guidelines and RCOG guidelines. List of activities: students should come to the labor room and should be able to connect the machine, CTG machine, on the patient properly, and then should take the graph and then should interpret the results. Portfolio entries: describe the NST reports and correlate with the patient condition, clinical condition. Logbook: number of NSTs done on high risk and low risk patients should be entered. Assessment: direct observation procedure skills, and even pictorial assessments can be done in this case.
Thank you, ma'am. That's interesting, but I have a doubt. So before making the students perform, so you can include 1 or 2 days that you demonstrate for the students and the student observe everything and take it as a note. Yeah. So the list of activities can include 1 theory session regarding what it is, and the other day you can demonstrate to the students, they observe while you perform, and then they perform. And one more thing, like you mentioned, like high risk cases in the end. So you have to decide whether you will send your student to perform on a high risk case or not. Okay. Under observation, fine. Yeah, then fine. Okay.
One more thing that I wanted to add is, you can keep minimum for each student at least 10 or 15. Only after that, you know, the elective is over. So that thing you can incorporate. Yeah.
5 students
each 10. Each 10.
Thank you, ma'am. Thank you so much. A big round of applause. Okay. Finish. Feedback. So assessment, just a slide on assessment. So you can do by giving the, monitoring the attendance, 75% is mandatory. Submission of report, students to be assessed in between and at the end of elective. And you can give your feedback and comments as a mentor, and you can take the feedback of the students also, like how the elective have been for them. So you can also assess while they participate in the grand rounds, present their seminars and case records. You can assess by their, looking at their submissions and reflections. You can assess by looking at their, you can assign them to do some posters, and you can assess by seeing them. And you can assess them by seeing their participation in patient education programs, and also MCQs, as many of you mentioned. So this was the last year's feedback we have taken from both the preceptors and the students. So if you observe, majority of the preceptors felt like the objective was achieved, and students' attendance was satisfactory. Like 8% were not happy with the attendance of the students, but overall majorly students' attendance was there. So coming to student feedback again, majority of the students opined that they had their objective achieved and they had a good interaction with the preceptors, and we also took a qualitative question where we asked whether they have any challenges. So most of the preceptors, we had challenges. Yes, even if I ask you, you feel the same. You have this time constraints. So how to engage the students from 9 a.m. to 4 p.m., especially in block 2, where you have to do your other clinical work. So this has been a constraint for many of the preceptors. And so last year it was between theory and practical exam, one block was posted, now it is after exam. So student didn't turn up for few electives, and timings, afternoon 1 to 4, many of the preceptors felt it was their lunch break time and it could be 2 instead of 1, but we can't help because it's from the NMC. And logistic issues, last year the logbooks were issued late, but this year we have corrected the logbook issue. It was very on time. So that is the importance of taking a feedback. So now again this year we will take the feedback after the electives, and which may help us to correct in the next year. So challenges by the students. So again time constraints, and last year few students felt like they were combined with different electives. So when the preceptor was not there and they were made to sit with the other elective, which they felt like the purpose was not served. And the interaction, many of them had good interaction with the preceptors, and many of them gave, like they were very happy with their interaction with the patients also. We had a very positive feedback from the students regarding electives. So these are the suggested reading from the NMC website regarding electives. So thank you for the NMC Executive Committee for providing us for the resource material and to conduct the CISP in our institute. Thank you.
Okay, first and the last person. And this person. We are coming to the fag end of our day 1 program. So today's the last session is on early clinical exposure, ECE. Okay. So you're all familiar with ECE. So here's an activity before starting to wake you all up. Yes. పర్లేదు నేనే ఆపేసాను కావాల్సుకుంటే ఆపాను యా మీరు అక్కడ పెట్టేసి మీకు చెప్పినట్లు చేయండి చాలు అక్కడ నుంచి సో ప్లీజ్ మీరు మాత్రం రండి లేకపోతే నేను నడుచుకొచ్చేస్తాను ఓకే observe this person, and I've given you the paper. Just write your findings.
So they thought we were doing sections without giving a trial for labor. So they were under the impression, I was like surprised. Correct.
Okay. Thank you. Any more wants to share? So what do you do if they come?
Actually 30 students have come on the day 1 near the endoscopy room. Only 10 have entered the endoscopy room. 20 were waiting outside because there was no place for them to stand. So after the endoscopy, when I went out, 10 people are sitting on the walls. Okay. 10 were sitting on the stairs, seeing their mobile phones, listening to songs. As madam told, like a layperson, they don't know how to be in a hospital, keeping loud music. They were like that.
Okay, sir. So what is the solution for it? What do you think?
When we send students for the particular early clinical exposure, there should be an available room for them so that we can teach them clearly. There is no, basically there is no place for us only to sit. So we can't afford to ask place for them. That's the problem, madam.
Okay, okay, sir. Okay, fine. Any more, ma'am?
Not exactly, ma'am, but there was similar situation. There was 30 students, but we sent 20 to the casualty accompanying a PG, and 10 our chief kept, and he was explaining the electrophysiology of heart conduction system and how an ECG is taken, and some people were sent to the ECG room and how the leads are connected, how the electrical activity, what is a neutral lead, and why there is left green and red color. That's how we actually introduced. This is how the patient came, the symptoms. So that's why you need the electrical activity. This is how the ECG is generated. That's what we said to the first year students.
Thank you. Any more wants to share their views about their experiences of having the first year students? Sir? Orthopedics department, sir? Aapka experiences share kijiye.
Our experience was good only, ma'am. So the students have come.
I heard because one of the student
HOD sir, son. Yeah. So first when they came, we put them in a classroom.
Okay.
So we provided them with tea and some snacks. Then every day
made them feel
comfortable, yeah. Then we went and we spoke to them about what orthopedics is, what do we do here in the hospital. Okay. After that, we took them around showing the OPDs, OT and wards.
Okay. Thank you. Okay, fine. Shall we move on to the class? Okay. My session today is to explain the concepts of ECE, describe the components, specify the time frame of conducting ECE. I have a solution for your problem. Share examples of ECE. Some examples I think you have already shared, you're all familiar with. Probably I'll just concentrate on what is important. First year students, when they come, this is their attitude. Now they say, oh, I'm bored of anatomy. Cadaver study, everything is fine. Now death of cadaver also. So, but fine. Why do I have to learn this? Oh, biochemistry Krebs cycle is so boring. Okay, I thought I'm learning to be a doctor, but I've never even touched a patient. That is the attitude of the first year students. They come and ask me, ma'am, teach me this. Teach me sutures. Why are you not teaching me suturing? I should revise my surgery postings. Okay, this is the attitude. Now, what is ECE? I don't know why NMC still uses this word preclinical, which we are no longer clinical. It is the phase 1, phase 2, phase 3, which we are using it now. So it bridges the gap between the phase 1, that is anatomy, biochemistry, basic subjects, basic science, with that of the clinical disciplines. That is the ECE. So an authentic human contact in a social or clinical context, which enhances the learning of health, illness, or disease, and the role of a health professional. He sits on the wall, he's playing mobile. Ethics, professionalism is learned by just seeing another person, how another doctor behaves with the patient in the hospital setting. Probably we can teach them by role play, but real life situations, exposing them to the real life situations is more effective, I feel. So what is early means? As early as first year. Nursing and all, nursing students and all are exposed to first year. During the first year they have the clinic. So why not our MBBS? So 2019 early clinical exposure was started along with a part of the CBME syllabus. So early clinical exposure is a teaching learning methodology which fosters exposure of the medical students to the patients as early as the first year of medical college. I think this concept is very easy. Okay, definition is fine. Now what is the purpose? Yes, what is the purpose of early clinical exposure? Is there a necessity, as I was telling you, exposing them to real life situation? Is it necessary? Why is it necessary? Why is early clinical exposure necessary? Why was it felt necessary by the NMC?
I think they would develop an interest in medicine early.
Yes, sir. First is interest. Yes? Mobile. Switch it on. To rectify. Okay, they'll know what is wrong, what is right. Okay. Then what else, madam? Why do you think early clinical exposure? Were you exposed to the first year, in the first year to clinics?
No, ma'am. Not.
What did you feel that time?
I didn't feel anything.
You didn't feel anything. Would you be happy if you were taught thyroid gland as a whole in the real life situation?
Yeah, it would have been better, ma'am. We would have known the knowledge priorly. Like, we would have been exposed and known about the topic priorly than at later stages.
Later stages, isn't it? As early as possible. Anything else, Kavya, you want to add? Why is early clinical exposure important? Why do you think it is important?
When they experience real life situations, they can relate it better to the subject that they are learning.
Don't you think so? Early clinical exposure, rather than me telling examples, they see a case and they can relate to the anatomy. They learn anatomy better. Anything else? Madam wants to talk.
Scenario, ma'am. The other day what our chief did was, he allowed the students to ask their biography. Like early clinical exposure, they felt very happy communicating with the patients and letting their problems know. After that, he gave the case sheet. And he gave the investigations, biochemical parameters and WBC. Now interpret it. It's what you talked with the patient, interpret it. And they were looking. Now read your basic sciences very well so that you will be able to interpret and treat these patients. That's what he said. However, you come to a final year course, you will still, this anatomy, these are the pillars. That's what they made them realize. Even though you come to clinicals, they still remain your pillars. That's what he gave a lesson to the students of first
year. The foundation should be strong. That's what he meant. Okay. Is that all? Weren't there any teachers who influenced you people to take up this subject? I took up anatomy 0 attempt because of my teachers, very frankly speaking, during internship. Yes, we get influenced by the teachers. Of course, doctors are teachers, but influence. So we learn basic clinical skills, early clinical exposure. We enhance their motivation, as you all rightly put it. We prepare them towards the purpose for which they have entered the profession. Enable the students to correlate what they are learning in basic science by learning the basic clinical skills and observing the relevant disease abnormalities. Encourage the students to learn professional behavior, learning by seeing, of a doctor by observing and being mentored. Yes, this is what you're doing wrong. There's nothing wrong in mentoring them. By a clinical teacher, it provides the context for application of their learning in practice. Yes, anatomy I have learned. Now, I mean, the gross anatomy of thyroid gland I have learned in anatomy. Now, if I see a patient, now how am I going to go about examining that? What do I need to look for? So that is what you're going to apply the knowledge. So what are the salient principles of ECE? It provides a clinical, I think one of you can read. What is the salient principles?
Provide a clinical context and ensuring patient centricity. The clinical context can include case scenario, videos, actual patient, simulated patient, etc. The presence of actual patients in every session of ECE, though not essential, is preferred. Therefore, ECE is exposure to the relevant clinical context in earlier years. Purpose of ECE is not to prepone the conventional clinical teaching, but to provide better understanding of basic sciences to clinical context.
So it's all self-explanatory. So these are the salient principles, thank you sir, of ECE. So need not be always a case. We can provide them with scenarios, provide them with videos, simulated patients. Okay, of course, if we are not able to accommodate everyone, okay, I think we can split them. and show them these case scenarios also. So elements, basic science correlation, clinical skills, and humanities. To apply and correlate principles of basic science as they relate to the care of the patient is the elements of ECE. Clinical skills to include the basic skills in interviewing patients, doctor-patient communication, ethics, professionalism, critical thinking, analysis, and self-learning. Humanities to introduce the learner to a broader understanding of socio-economic framework. This is also equally important. Okay? And cultural context within which the health is being delivered through the study of humanities and social sciences. Okay? These are the three elements of ECE. So where do we use them? Yes. We can use them in the classroom setting, wherein we can bring a patient to the classroom itself or case discussion. We can use, it can be a hospital setting, like we send them to the hospital for a week, where there is a hospital visit or a primary care exposure, or a community. They visit the community, isn't it? Family adaptation program, where they see all the, that's like a project work you can give them, these community visits. So context and both are relevant. Where to use them? Yes, this is another slide. Training in basic skills and demonstration of clinical problem. These are some of the snaps which I've just taken. So patients or paper cases, basic science correlation in the classroom setting, primary care exposure in the hospital, community visits in the community settings. So example, they have given some examples in, we have a ECE already been, we have a book, early clinical exposure book, wherein they're given examples of what are the topics to be covered in ECE. One of the topic is Parkinson's disease. It can be a patient or a video or a simulated patient or a role play. So what are the objectives here? What are the objectives? To demonstrate understanding of alteration in the normal function of the basal ganglia and the clinical expression, anatomical and physiological basis of signs and symptoms of Parkinson's disease, observe examination of motor system, that's a tone of the muscle in a patient with Parkinson's disease. So this is all given by NMC. So similarly, we can have our own ECE, okay? Varicose veins, for example. So for varicose veins here is understand the alteration in the normal anatomy, physiology of peripheral vascular system and their clinical expression. Demonstrate understanding of the principles behind clinical examination of the varicose vein. You can come up with n number of outcomes, what is relevant for the first years. Okay? So similar examples have been given. So what the patient should see, deviation from normal to be observed and noted when exposed to clinical context, like what you all have done just now. You have observed and you have noted down. Now what to observe also has to be mentioned. Like it should, say what do you observe? Like you should give them a proper guide. If it is varicose vein, what exactly you need to look for. So we have something called as observation guide which is to be provided. Okay? Beautiful scene is seen. I think the same way, you can see many things, but what you need to look, what is relevant for a first year person or first year student, Indian medical graduate, what he need to do in a hospital setting is to be decided earlier. So going back, planning of activity and its distribution. Basic science correlation. Earlier it was nearly 30 hours being allotted, but the latest says 27 hours, so 9 hours for each department, which has been divided as per our convenience. We are dividing it. So it's 3 hours session per month for 5, so amounting to 15 hours. It can be what ECE can be planned. It can be charts, graphs, or videos, graphics, sorry. reports, it can be field visits, either in the hospital or in the lab. Skill settings can be 12 hours with preclinical faculty equipped with observation guides to specific cases, or it has been demonstrated by the clinicians and observed by the first year students. So this is how the activity and planning of ECE goes. So planning, again, in that 3 hours of clinical skills, further it is divided, 30 minutes introduction and instruction, 1 hour, 30 minutes, a hospital visit, 30 minutes can be a summary and conclusion. This last 30 minutes, what did you learn? What did you see? So what? So reflection of the students, that's also equally important. So don't forget to take the reflection. So this is, I think, this is all over. I think we finished this first. Now, if you are posted to an OPD clinic and have been told that the next patient to be seen is a 24-year-old female who has signs and symptoms of hyperthyroidism, and your teacher has asked you to observe hyperthyroidism case. So that was a normal patient who had come. If it was a hyperthyroidism case, what exactly you are trying to look for? What are the things you look for in hyperthyroidism? Staring, look. Okay, sir. Tremors, okay. Sweating, okay. Hyperthyroidism. So please write down all this. Yeah? These are the things you should look for. Okay. First, the what is it? Gender, age, if possible. His appearance, physical appearance. That's all. So there are different ways of looking at the same situation. Students may observe everything superficially or look at totally unintended things which we don't want. So observation is not neutral. So returning to the example, what is the student being asked to observe? So what prior knowledge does he or she has? What might he or she learn from the observation is equally important. So we should, as a teacher, should know what exactly they have to look at. So who, what, how, and for what. This is the spectrum of observation, which is to be kept in mind. So far, so clear? Yes, I think this is all ECE module 1, acute MI. It can be, the goal is the student should be able to recognize the relevance of coronary circulation in the diagnosis, patient care and treatment of acute MI. So it can be a case, or you can demonstrate it in the form of a role play in the classroom setting. Okay, the topic of basic sciences here is, I'm teaching about heart, blood circulation of the heart, especially the coronary circulation. So when I am doing that, I can introduce this module. Okay. So I write down the objectives. If it is coronary, I'll just give you one example. I'm just going to rush through it. So describe the mechanism of regulation of coronary circulation, role of lipoprotein in the derangement of coronary circulation, explain the biochemical changes which occur in acute MI, identify the clinical manifestations secondary to the decrease in the coronary circulation, and explain the basis of treatment. Basis of treatment, it is not the treatment, because first year may not know the treatment. So what is the basis of treatment for MI? So in this way you can create as many, this is an example for a clinical case. Please, and we have something called as a facilitator guide. What is the probable reason for chest pain? Why regulating mechanism failed to meet? So we should be having the answers all this. So that we can explain to the student. Now this is with regards to the case history here. Similarly, we can have a lab report, give them this lab report of acute MI admitted and use the same, taking care not to disclose the identity. So again, what are biomarkers, cardiac biomarkers, what does serum lipid level indicate, role of dyslipidemia, and what is the next step we use for the management of acute MI. So ECE, principles, elements, what is the necessity for having ECE, what is the prerequisite, what is the role of the teachers in the hospital when the students are posted to the ECE. So ECE can be done in the hospital setting, in the classroom setting, or in the community setting. We can use videos, charts, graphics, what else? Simulated patients or real patients for the ECE. Okay, that's the gist of what I want to tell. Do we assess? Yes, we assess ECE. It can be a part of formative, part of internal assessment, or it can be summative assessment. So for example, this is what I was talking about, observation guide. What are the steps which are taken before? For example, if the patient is, if the students are going to the blood bank, what are the steps taken before blood transfusion? How is the blood collected, stored, screening, what has been done after the blood collection? What is component preparation? What tests have been done before issuing a blood bag on requisition? Okay, so this is to be done. So conduction. Who conducts ECE? It's the role of MEU members to train the faculties, have a FDP on faculty development program on early clinical exposure. The implementation, monitoring, governance has been done by the principal or the dean, the head of the departments, and the curriculum committee members. So evaluation, take feedback from the students and written feedback from the faculty. So feedback from the student, we can ask how useful or helpful was ECE module in improving your knowledge about the coronary circulation, if it was MI case which you have done. Components of the program that has helped you learn. Did ECE module make learning basic science subjects more interesting? Are you motivated to read further on the topic as a result of participating in the ECE? And suggest changes in the program that will help you still learn better. This is the type of questions we ask as feedback from the students in early clinical exposure. Even the faculty who have participated, take their opinion as to whether the outcomes were achieved and suggest you can suggest, you can advise whatever for any improvement, if required, you can give your opinion. So this is the early clinical exposure website, and you get the contents of the manual of early clinical exposure. And I thank the NMC Executive Committee for providing the slides, and also for your active participation and silent hearing. Thank you. We come to the end of day 1 session. I think the rapporteur for tomorrow morning, Dr. Vijayta ma'am, will start with you tomorrow. Anything else you want to tell? Feedback forms have been please fill the feedback forms. Kindly fill.
Received in your WhatsApp group. So please go to your CISP WhatsApp group. The feedback form is being circulated. Please submit the form and then only please you can leave. As directed by Dr. Ramya Ramakrishnan ma'am. So there are options from 1 to 5. So please scroll. So the options range from 1 to 5, 1 being strongly disagree to 5 being strongly agree. Please scroll it.
CBME. What we have to tell summary of the report here.
All of you please have your breakfast tomorrow morning at the library lobby at 8:30 a.m. And please be gathering here by sharp 9. We'll start with the rapporteur's report.
You ask her.
Okay, please come back by 8:45 a.m.